Open the main meeting. And so welcome to the Public Board of Cheshire and Merseyside ICB. I've got two apologies, Andrew Lewis and Warren Escalade, and I can confirm that we've got accuracy. Do any members of the board have any declarations of interest that are relevant to the agenda items today? No? Okay, thank you. I'm going to go to Chair's announcement, and I'm going to start with this one. I think all of us will know that next week, on the 29th of July, that's the one-year anniversary of the tragic deaths of Elsie, Bibi and Alice, and the injuries that were inflicted on a number of other people. It's a time that will make people will feel very raw about it again, as we always do on these anniversaries. And we also know, don't we, that during that time, the communities came together, people came together to do the best they could with that horrendous tragedy. I'm going to ask Debs to say, who leads from Southport, to say a few more words about this for us.
Thank you, Chair. As Place Director for Sefton, I wish to say a few words to acknowledge the Southport 1 year on. As we approach the 29th of July, we wish to remember and pay tribute to all those directly affected by the tragic incident of last year involving the murder of three young children. This period has been incredibly hard for the families of Alice, Bibi and Elsie, and all those children and adults who suffered psychological and physical impact. We must also remember the local people who rushed to support and our amazing emergency responders. There will be a 3-minute silence at 3 p.m. on the 29th of July, which will be recognised by council bodies, public bodies and the council and ICB. Psychological support remains available to anyone directly affected, and we've seen an increase in demand for these services leading up to the anniversary. We will ensure that there is support available leading up to and beyond the 29th of July in Southport. Sefton Council has asked me to thank health provider colleagues, Cheshire and Merseyside ICB and the Sefton Place team for leading the psychological support offer, which continues to be made available. With special thanks to Merseycare, Dr Rob Campbell and his team, Dr Rob Caldwell, Clinical Director Sefton, Kerry France and her team, Lisa Cooper from Alderhay, Amanda Comer from Mental Health Matters, and our wonderful CVS partners who have stepped up for to support the recovery programme in Southport. A full communication pack has been made available, Chair, which includes details of the way in which we can recognise the anniversary. And this has been developed with families of Alice, Bibi and Elsie. Thank you.
Thank you, Debs. So let's move on to another topic. Firstly, I'm delighted to welcome Del Curtis, who is formally Del, Chief Executive of Cheshire West, local authority, has joined us as a partner member, taking over the seat that was vacated by Professor Broomhead's retirement. We wish Steve well, but we really welcome Del. Thank you for joining us, Del. A few other good announcements. I'm really pleased that Tony Foy here has agreed to continue and stay on for another 3 years as a non-executive director of the ICB. Also to announce that Neil Large, who was a non-executive director of the ICB, has now taken up post as chair of the Countess of Chester, and as a result of that has resigned from this board. And currently that role is being undertaken by Mike Burrows here as an interim non-executive director, whose appointment will run till the end of June 2026. So thank you for all that. And finally, one announcement from me. You might have seen this in the press already. Early last week it was, I announced my intention to retire from this role. I'll say more into the future, but I guess what I feel at the moment is very, very mixed emotions about that decision. It's a decision that's been driven by my own personal circumstances, wife and family telling me off for not being at home, so I need to do more of that. And I'll say some words into the future. So thank you for that. Let's go on to the experience and achievement story. I don't know. I've not got any indication that, that there is.
I started smoking when I was about 12. We robbed a pack of fags off my mate's mum and dad. She'd come back from abroad. So we were just terror teenagers. And we started smoking, and I must have smoked about 10 in one go. And then started smoking, and I carried on smoking and never ever give up until I found out I was pregnant this time. I didn't even with me first. So, so I was smoking 30 years, on and off, basically. Well, I found out I was pregnant last year, and being 41 at the time, 42 at the time, I just thought it's time to give up. But plus, when you go in and sit down with the midwives, they put you on a carbon monoxide meter. So when I seen what the baby would be getting, mine was in the red, it was 12. So when I seen what the baby was getting, it was like 2. And even that was too much for me. I just felt awful, I just felt sick at the thought of the baby getting any of the carbon monoxide. Then I went to see Sinead, which she's in Whiston Hospital. She said, when do you want to give up? I said, tomorrow, because I'd already had about 4 in the morning. I just thought there's no point. So I give up the next day. And yeah, that was that. Not smoked since. I found it easier than I thought it was gonna be, but I was still, I ate a lot more, but I was pregnant at the time, so that was normal anyway. And it's still, like I said, I had my vape, so that helped a lot. The nicotine replacement patches help a lot as well. I tried to do it once before, but I was only on 10 milligram, which just didn't even touch the sides. But when she put me on the 20 plus my vape, I found it quite easy. I went on my friend who I worked with, who actually gave up with me. He smoked for years. We just lent on each other basically. Yeah, and my son as well. My son was really good, and my partner, he was really good as well. He wanted me to give up for years, but I just wasn't ready to give up. So I've got more. My life's changed for the better because I've got more money, and obviously I've added on to my life. Hopefully, years onto my life with giving up smoking. I feel a lot more healthier now than I've done in a long time, and I'm 42, so I feel a lot more. And I've got a lot more energy, which I need with a newborn. Just to try and do it, just try your hardest and reach out to people that can help. Try nicotine replacement, because one thing might not work for one person but it'll work for another. I tried the Champix years ago. They didn't work. They were tablets. They made me sick, but there's a lot out there that will help you. It will help you, and it'll extend your life in the long run.
It was a fantastic example of our Altogether Smoke-Free programme, something the ICB is funding alongside our local authority, public health teams really, and we have NHS treatment tobacco dependency services in our maternity services, for example, and our acute trusts, but the importance is joining that up in the community as well, so hopefully you can see the positive differences being made by that investment.
Thank you, Ian. So as normal, we don't really discuss the experience story here. We'll help set the tone, and we'll move on to the Chief Exec's report.
So good morning to you all. I'm pleased to present my first Chief Exec's report in post. This is my 8th week in post, and thanks to everyone for making me feel so welcome and supporting my induction. What you can see in this report is a collection of activities and programmes and risk mitigation that we're undertaking. What we're trying to do as a senior leadership team is make sure that we're looking at the here and now, and you've heard colleagues Rowan, Anthony, Mandy, particularly talking about working on performance improvement for the here and now and preparing for winter. We also will talk through this meeting and our meeting in private later around financial recovery, another area of our here and now work that we need to do. But also we need to think about the future, and that's why I'm delighted that we've got neighbourhood healthcare framework coming for board approval today, because that is about setting out the foundations not only in the NHS England planning guidance for all NHS organisations this financial year, but it is about planning for the future, because we all believe in providing care closer to home in people's communities and being informed by local people's experiences. There are a number of things in this report where I'm going to ask colleagues to come and share some updates. In the here and now, I wanted to ask colleagues to talk about our concern around measles in our community at the moment. We can't get into specific patient cases, but I just wondered if we could particularly ask Fiona and Rowan to talk. Are you going to, Ian, start? Thank you very much. And the public health drive around measles at the moment. So calling my colleague Ian. We also need to recognise industrial action is taking place at the moment. So after we've heard from Ian, I just want to invite Anthony to come and talk as well.
Thank you. So you'll see from the papers in the pack a bit of last year there was a measles outbreak, and again nationally the national incident has been recorded in that. We've had a outbreak ongoing in Knowsley, and we've seen approximately since January 63 cases across all 9 areas of Cheshire and Merseyside. You'll see a big drive around measles, mumps, rubella vaccination. We've got a bit of a variance between those who've been fully immunised and those who have not. The target is around 95%. Some local authorities around 77%, some 90%. But that masks some of our communities that have much lower uptake, and that's where you're seeing some of those outbreaks happening. NHS England currently are the regional commissioners of those services. There's a number of things that they've done to write out to our GPs, highlight those who need more protection. We're asking people to prioritise those who have had no MMR, because as you get to for full protection. They also commission our school-age immunisation services. For Merseyside, that is covered by Merseycare, and they'll be putting on a number of additional clinics and support during the summer as well. There was also a number of pilots that we're running with some of our primary care networks where low uptake takes place, and there's an evaluation going on about that, how we can remind that uptake. The ICB is part of the outbreak response. You'll hear about our Live Well service. We've run sessions that go into do in targeted areas and working with our local authority public health teams to identify where best to do them. And we're reliant on our community sector and voluntary sector too to help promote them messages in a local area. We've also implemented our additional out-of-hours response for GPs and put in more clinics, making those available to those areas of outbreaks. But it really is to highlight the importance of getting vaccination in place and making that easily and accessible. There is one other area that we are also wrote out to all our GPs, our medical directors, our infection control leads and community pharmacies, and reminding them that the importance of those staff who deliver direct patient contact need to be protected as well from MMRs too. So just a continual drive and push that, but that is done jointly with the UK Health Security Agency, our local authority public health teams and NHS providers. I should say that we've been supporting Alder Hay as well with opportunistic vaccinators in there too as well to try and drive that up.
Great. Thank you very much, Ian. And colleagues will see in item 18 in the meeting, we'll then move on to seasonal vaccination, so we can pick that up as well in preparing for winter.
Just before you go, Ruth?
Sorry, I was going to ask a question about measles. It's really helpful that you've outlined that. I suppose my question is, what impact have we had so far in terms of vaccination uptake? There's no data at present to show that we are actually reaching the people that we need to reach. I know it's NHS England's responsibility, but it'd be really helpful to know quite quickly whether the vaccines are getting to the right people. Have we made it easy enough? I saw some publicity which said, you know, ring up and make an appointment. And I don't know whether that's sufficient and timely enough to curb this outbreak and up our vaccination. The other quick point, MMR is crucial also to prevent mumps and rubella, and women of childbearing age may well have missed out on their childhood vaccinations. So are we doing enough to tell young adults as well that if they have missed their childhood vaccinations that they can also come forward? So I think we really need to seize the opportunity to try and curb this spread of this disease. I've seen major outbreaks in other parts of the UK, and it's vital that we get on top of it. Thank you.
So as an ICB, we've created a dashboard that monitors those uptake as well now from that taking place. We already have anecdotal findings from our Live Well service about how many new children have been taken up through specifically targeted work in those at this time, but it's something that we will collect and collate as we move forward. I think this is where maybe some of our educational partners sitting around the table, as well as schools and the universities, thinking ahead to September about how we drive those messages to around uptaking young people who might not have been protected. So we'll do that through those established links.
Thank you. And your challenge is very helpful, Ruth, not only for this year, but potentially in future as the ICB, if we take on direct commissioning, as you appreciate, for Cheshire and Merseyside. So we have that, it comes through from NHS England. This is really helpful learning for us when we have more control, as it were, on this. So thank you for that. Just focusing on the here and now, we're very conscious of industrial action starting tomorrow. I'm really grateful to Anthony for representing the system alongside a number of other colleagues, including Rome, around the table here today for our system. I attended a briefing yesterday, which was led by Jim Mackey, the National Chief Executive of NHS England. The Secretary of State spoke to that, which was to 240 ICB and Trust Chief Execs across the country. Anthony is very much involved, and I know colleagues around the table, particularly working in trusts, are very much involved in this. But if I wanted to hand over to Anthony and Rowan just to give an update on this, and also, Chair, Anthony may need to step in and out of the meeting today to join various updates as well. Thank you.
Thank you, Cathy. So, as part of the ICB's emergency preparedness response and resilience arrangements, we do have a tried and tested and published incident industrial action plan. When we were notified 2 weeks of this action, we immediately invoked that plan. And over the past couple of weeks, we take the premise of planning for the worst and hoping for the best. And we put all the steps in place with our 16 provider colleagues to plan services for this period of industrial action. There is always an unknown in that we do not know the precise volume of individuals that may take part in action, but we plan on the experience of previous rounds of industrial action and also the intelligence that we do have. Our priorities are to preserve the high urgency elective, cancer and elective urgencies, emergency services, cancer services, but there will be inevitably some level of impact on non-urgent elective and outpatient activity during this period. Those patients that are affected will be very quickly contacted if they haven't already been done so in advance of the action, but will during the period of action, and a suitable date for reinstatement of their outpatient appointment or elective procedure will take place. We were informed yesterday that the strike will go ahead. There was always that hope that there'd be a last-minute agreement, but we know for sure now that it will. And therefore we will enter into our command procedures over the next 5 days, which will work around the clock 24 hours. There is an incident command rota, a clinical command rota, a comms rota, and a people rota. All of that is replicated within our individual providers. We will maintain oversight around the clock, and if there are any patient safety concerns apparent within any individual service or provider, then there is an escalation process whereby ultimately it could reach a national panel for consideration between the national team and the BMA, which could result in a return to duty to maintain patient safety during that period. So tried and tested and adequately prepared. Rowan, I think it would be useful to talk in particular about some of the public messaging that we've given about access.
Thank you, and very much recognise here we are with our public joining us today. The essential things to say is the NHS is open over the next 5 days. And whilst we respect the right of our junior doctors, our resident doctors, to undertake this action, we're doing all we can to mitigate the disruption, the inevitable disruption this will bring. But where people out there are critically ill or sick, they dial 999 and an ambulance will arrive in the way it always has, and it will convey patients to an A&E department that remains open. We'd like all of our public, I guess, to be as thoughtful as possible through this period, and resources like NHS 111 online are a really great place to start that will direct patients to the most useful approaches to care, whether that is off to your community pharmacy, maybe through primary care, urgent treatment centres and that sort of thing. I think it is fair to recognise that there will be disruption, and what we say to people out there is, if your appointment is being impacted, you will know already. So if you've not had a letter to the contrary and you've got appointments through next week, come forward in the way that you always would. You can expect that appointment to go ahead. We are protecting and preserving as much routine care as possible. In particular, cancer operations are happening next week. I know I am taking cancer patients to theatre next week. Cardiac surgery is going ahead next week. Neurosurgery is going ahead. But it might be challenging for people in A&E, for example. And we ask also for that kindness, because there are staff who are stepping into slightly different roles for which they are competent and trained to do, but perhaps a bit different, and where there might be disruption and delays. We ask that our staff remain kind to each other through that, and that our patients recognise there are people who've stepped into care through next week as well in difficult times, and we will work our way through. And we hope most sincerely that our government and our unions come together to resolve this, because as doctors we get out of bed every day to care, and that's what we will work so hard to preserve through next week. I've met with our medical directors this morning already, and I am assured that we are prepared and ready. We will meet again this evening and then again tomorrow morning. Thank you, Chair.
So those are some key issues this week, this month. There are other areas of my report that talk about work during this financial year, particularly our financial turnaround. We're in a second phase with PricewaterhouseCoopers, PwC, on financial turnaround for us as a system, and that includes all trusts in our system as well as ourselves as an ICB. And I know we have a finance report later where we'll be looking into that in more detail, and we had an ICB Finance Committee meeting yesterday for oversight and scrutiny of that. We are having to make challenging decisions, and I'm really grateful to lots of people around the table, working in the NHS, working local authorities, working with us alongside us in the voluntary sector, in trying to make the right decisions, in making sure that we're spending money in the most effective way, getting value for money for the public purse, but also delivering safe quality care. And we'll come into that later in those variety of reports. You'll also see a theme throughout this my report and this meeting and previous meetings around reconfiguration of services, and we continue to play a role in that, in supporting and challenging our colleagues who are working on reconfigurations across the Cheshire and Merseyside areas. We also have got an update there in the report on behalf of the senior team on responding to NHS reform. Some of that we'll cover in this meeting, some which is much more sensitive at the moment because we're working through plans, particularly how this affects staff in the ICB. We'll look at later in the board meeting in private as well. But we note that integrated care partnerships, ICPs, will no longer be going forward formally, but we also want to work out how that works for us, because we still believe in partnership working across health and care. And I know in talking to colleagues both in local authorities and the voluntary sector, we want to work on our response to that, and also with Health Watch, the changes for Health Watch as well. We believe in independent local resident views and voice in our work and our decision making, and we need to also work that through. Yes, we will be undertaking engagement and working with residents in the new way of working for the ICB, but the independence is really important as well. So I know, Louise, your colleagues at Health Watch and yourself will be really helpful to us in working that through as well. And we'll also hear later on about performance, particularly in urgent and emergency care. It is an area of a priority area for us on performance improvement, and colleagues will talk later in this meeting and the board meeting in private. So that's a summary for you there, Chair. I'm happy to take any questions, myself and my colleagues in the senior team.
Thank you. Questions, comments for Cathy? No. Okay, should we move on? Mark? Oh, somebody asked a question.
Chair, if I could just, I wanted to also note the risk summit that took place on Monday this week, working with a particular group of clinicians that Rowan and Chris led. It might be just helpful to hear a very brief update. I know we had an update through it on the questions we received in public earlier, but what we can commit to also, particularly through our quality committee, is also the results of that, and we'll also be sharing that with our colleagues at NHS England Region. But I don't know, Rowan and Chris, very briefly, whether there's a key update for board members.
I think we spoke to much of it earlier with the questions, formal write-up, but more importantly, it's that this risk summit was not the start and finish of something. It was not, a single event. It is the start of something. And even we had colleagues who presented who want to describe that it's the start of a movement to better manage and shift our risk across the system. So the formal write-up heading through the work streams that follow on from it, and that we will formalise that with improvement partners as well. And indeed, we are seeking, through routes to funding and some regional funds as well, to very formally embed some of this improvement methodology across every part of our system. I'd welcome if there are any comments. I know certainly Chris and Louise were at that event as well, if there's anything to add. Thank you, Chair.
Thank you. Chris?
Yeah, just, Louise may come in on this, but I think the important thing, our local authority colleagues were there, and Louise was there representing Health Watch, but it was about putting the patient and the member of the public front and centre in this. And I think the words that resonate with me, I think one of our local authority DASs did say, there's no bed like your own bed, and that's where we should be advocating that people sleep. So that really stuck with me.
Thanks, Chris. Louise?
Thank you. Yes, it was a really interesting day, and there was lots of very open discussions and some good sharing. I think one of the areas, building on what Chris said in terms of people and beds, is the clinical aspect of getting somebody out of a hospital, obviously, is massively important. But the social aspect of getting somebody out of a hospital is equally as important. And there was much discussion about how we build in from the moment somebody arrives within the hospital. Yes, clinical criteria to discharge, but what is the social criteria for discharge, be that back to their own home, into a different place, whatever that is, that needs to be set as a priority. So the urge is clinical criteria to discharge, social criteria to discharge, absolutely interwoven from the second somebody arrives in. That's what gives us the path. And understanding that individual, be it through a one-page profile, something that means that we know the capacity of the individual when they arrived into the hospital, to ensure that we do not help hinder them not being able to do those same activities when they are discharged. Really positive, lots of sharing happened, and there was some good challenge and debate in the room as well, which was good to hear.
Thanks, Louise. Cathy, I think you come back in.
Yes, so then in thinking about the here and now, but then planning for the future, what you have around for you all as board members, but for the public to see, is our initial response to the 10-year health plan. And thanks to Claire and Ian and other colleagues who have done that initial response. The plan only came out a matter of weeks ago. I know there's more work that we need to undertake in responding to that. And I would say that would probably come an update to the September meeting, and then more in full at the following meeting, because we also need to plan the model ICB arrangements alongside it. But I really want to thank colleagues for putting that together, and I really encourage people to disseminate that out, because you can see how already we align with much of the plan, particularly our neighbourhood health working, some of which have been going on in Cheshire and Merseyside for years, but also that we want to build on that further. So so hopefully that's a helpful document for colleagues to use in the system.
Thank you, Cathy. So, Mark, should we move to the finance report?
Thank you, Chair. This finance report is an update to the board on the position as at month 2, so May, within the 25-6 financial year. Provides information on the financial plan performance and also some wider measures of financial and operational performance, including efficiency, productivity and workforce measures. As at 31st of May, the ICS system was reporting a year-to-date deficit of 67.1 million against its planned deficit of 67.3, so a small but favourable variance of just under £200,000. I'm keen to stress this excludes the deficit support funding and is the sort of the true underlying position in terms of our national position. That variance does exist on the provider side of the system, with the ICB having a break-even position within the reporting month. Some of the further information obviously included in the report, particularly in Table 1 on Section 2.3, And equally in terms of the chart on section 2.5, which gives a description of how the journey for the year needs to look in order for us to meet our year-end position of the 178 million deficit, which is in line with national expectations. In terms of the summary of the key month 2 INE and CIP metrics, they're also included in table 2, and I'd like to just draw your attention to a few of the aspects that are within the bullet points under section 2.7. One key metric that we're very conscious of is that the system has incurred around 38% of its overall deficit within the financial year. So that's around, so an equivalent 2/12 would be around 17%. So we've used more of our resources in the first 2 months than the normal profile, and obviously one that leads us towards having to make some significant gains in the remainder of the financial year. And you can see that within the charts as per the previous points. Also to say, one of the characteristics of our system is about our ability to deliver our cost improvement programmes or our cash release in efficiency savings on the ICB side. And again, you'll see that within the pack that our year-to-date efficiencies are lower than planned, and indeed some of those have not all been delivered recurrently, which obviously gives us a further problem should that not be recovered throughout the rest of the year. I should also stress that there's an additional level of stretch and challenge within each of the provider and indeed the ICB systems, which sit outside of those cost improvement programmes, around 155 million at the time of the report, which again we're working closely with system partners about how we resolve that. And again, that leads to some of the work that Cathy has alluded to around the turnaround piece with PricewaterhouseCoopers. Paragraphs 34 to 40 of the report give a bit more information on that and progress to date, but we continue to work to mitigate that level of stretch within the system. And then last but not least, around cash, which again is further information within the report. Levels of cash within certain providers are challenging and are diminishing, with a minimum of 4 organisations being expected to have to apply for external cash support from NHS England from and within and around sort of month 5, month 6 period, which obviously is not too far away. I'll return to cash later on, just to briefly touch on deficit support funding. With regard to the ICB position, whilst relatively early within the year, we can see some emerging pressures in respect of our independent sector contracts, particularly around ophthalmology, and mental health contracts, particularly in respect of ADHD service provision. On a positive note, we're seeing expenditure on continuing healthcare and mental health expenditure being in line with or lower than our plan and assumptions, which is an important start to the year given some of the challenges we've had over the last 12 to 18 months. And a big thank you at this stage to colleagues who are working in this area, in particular Mandy, Alison and Simon for all their work in leading the programmes of work to help support our financial recovery. Further information then in the pack on section 2.12 and onwards regarding more detail of the provider performance, including key aspects around pay, which includes the use of bank and agency, our delivery of cost improvement programmes, again, as previously mentioned, and some of the cash points that I've established there. Keen to stress at this stage that we've increased our governance and our escalation processes during the first quarter in order to keep a close eye on those and work closely with trust leadership teams to make sure that we're actioning mitigations as a system approach. That links me to the final section within the report, which again leads to the item that Cathy introduced in the Chief Exec report about the turnaround position that we're in our financial recovery. So I won't repeat the points made there, but we are in the early stages of that follow-up from the diagnostic work. In addition to that, a gentleman called Simon Worthington, who supports PwC and NHS England, has also been asked to help support the system, and he's currently undertaking a number of aspects of review with ourselves and with the providers, reviewing cost improvement plan delivery and also reporting and forecasting outputs, which we hope and expect will help bring some greater consistency to our approach within the system and will complement and underpin some of the work undertaken by PwC. The final element just to bring to your attention is the issue around cash, and again draw your attention to the relevant section within the pack. In particular, specific issue regarding the withholding of the deficit support funding for quarter 2, so that's around £44 million of cash resource into the system during that period. We are working with colleagues at NHS England about how we can continue to access that. The technical guidance suggests that we can recover that during quarter 3 should we meet a number of measures which we need to work on and through with the PwC and NHS England team, but clearly that's a significant impact on a number of our organisations in terms of cash flow and cash flow planning. We continue to develop those approaches, and again we had a good discussion yesterday at the Finance Committee about some of the details around that. I will conclude there, Chair. Just ask the board to note the financial position at month 2 and the risks as described within the paper regarding the delivery of the financial plan. Happy to take any questions. Thank you.
Thank you, Mark. Any questions or comments for Mark? Mike?
Couple of observations. That the cash position is extremely concerning, and the measures that may need to be taken in response to that cash position in certain organisations could be detrimental to the provision of care. There are mechanisms available to us to apply for cash going up to national level to seek that, so it's an extremely concerning issue. And it tells a story in terms of where the aggregate financial position is across the organisations. And I'll turn to that now, because there's 3 bits of information that we need to add together in this report. If you look at chart 1, the financial performance, yet again we see a profile which is back-ended. So it's difficult for us at this early stage of the year to understand whether that recovery in the profile that you see towards month 11, month 12 is actually going to occur. And that's not good. Because when you then look at the cost improvements, what you'll notice is that there are still a number which are in development, in consideration. They're not yet there. They're categorised red and green. And some of the amber ones as well, we're not certain of their delivery. So we've got to consider on that basis that we're carrying a very considerable amount of risk in terms of the ability to hit that aggregate position. If you look at the headcount chart, which is the one on page 49, again, that tells a story which ties into that concern I've expressed around the delivery of the cost improvements. It suggests to me that the progress that we're making in terms of cost improvement delivery to date isn't great. It's an artificially high starting point if you look at where we were at March 2025. And the plan profile, one has to assume, doesn't include a full set of worked up cost improvement programmes. So we should actually be getting ahead of that profile, not staying with that profile, to give us the confidence that we're actually going to hit the year-end position. So we're carrying a lot of risk here, and separate from this discussion, we'll need to work with the other parts of the NHS to work out how we respond to that and what our role is in the response and what the role may be of the regional team, etc. That's my first set of comments.
Thanks, Mike. Are there any other comments before I make some comments? No. So the board should be very fully aware that we are in turnaround. We may not have that official title yet, I don't think, Chief Exec, but that's what we're in. And if you think through the implications of that, both in terms of the time and effort that the management team have to put towards ensuring that we don't spend money that we haven't got. We don't disadvantage patients elsewhere in the system or elsewhere in the country because we're spending money that we haven't got. It is enormous and considerable. And it's, as Mike's emphasised, we have high levels of risk in our plans at this moment, and what we expect to see coming from the management team is more assurance about the delivery of those plans, so that we can get our cash as well as our underlying financial sustainability into a good position. And we'll hear more about that in part 2 in a lot more detail at an organisation level, which isn't appropriate to talk about in public at this moment. But I do want to come back to cash. Okay, it's, members of the public, members of staff could well read our report and see that for some organisations they've only got 1 day's worth of cash. I might think that what assurance, if any, could we give to those members of staff about whether they get paid or not?
Thanks, Chair. We work really hard as a system, I think, is the first point of comfort, I suppose. I think Cheshire and Merseyside is often recognised as a system that on these types of issues does as well as any in terms of using cash management principles, making sure that we're paying invoices on time to each other to make sure cash between ourselves is flowing. In the Finance Committee yesterday, we received an update on the MOU, or the set of principles by which we're helping organisations commit to working together. There are some, what I describe, soft measures around the goodwill that we ask of organisations, but equally there's some harder measures that, again, we're asking organisations to commit to. And each provider will be taking that paper through their own governance and their boards over the coming weeks and months in order to cement that within our system working. We've got some good, unfortunately, some leading lights, if you like, in terms of cash management principles who've had to do this hard graft. So, you know, that learning is being spread and shared. So colleagues, for example, at Wirral Hospitals had a really difficult end of the year last year, and they had to put into practice a number of measures, which again we've looked at and learned as a system, and I think that that's been deployed. I suppose fundamentally we work through prioritisation of how and where we can use the cash that we have available. Obviously the last resort being to push out sort of creditor payments, and I suppose the last resort being obviously the payment to staff and other suppliers. So we you know, absolutely take on board and agree with Mike's concerns. It is one that feels almost like potentially going over the edge this year, I suppose, in terms of the crude numbers that we see. Certainly the withdrawal of the deficit support funding, which I understand why that decision has been made, but it certainly doesn't help us in the relative short term. What we're very keen to do is understand from colleagues at NHS England about what would it take to re-earn that, and you know, what are the measures, what are the metrics, what are the things that you're asking us to do in order to do that, because again that's a real key and important part of our system. So in terms of reassurance, I suppose we're doing everything that we can within the technical rules, within the, again, soft and sort of hard mechanisms that we have, and we're engaging with NHS England both regionally and nationally about you know, the clarity of the position and trying to make sure that they're fully aware of the challenges that we face. Often one of the questions is, well, you know, we can see, if you like, the cash balance within the system, and you know, well, that looks a lot of money over there. Why does it look like that? So being really clear why our cash balances look as they do as well, because again, you'll see some from the report, some of our organisations do hold a level of cash balance, but it's often for specific items such as an EPR system deployment, let's say, in some parts of our system, or some capital expenditure that, again, they have firm commitments about, which again aren't necessarily at front and centre within a report such as this. But we're doing all of that, and that's through our cash management principles.
Okay, that's really helpful, Mark, and thank you for that. So I would summarise that we've still got, words not headroom, is it? There's some buffer that will enable us to get through these difficult periods, but it's really, really difficult to do. I think that's what you're...
At a system level, yes. I suppose at an organisational level, that's where the challenges become, because that organisation will have commitments largely against that, and it will require a level of A, goodwill, and B, a level of system working in order to transfer that resource, should that be the route.
Good. Just one other topic very much associated with this. People will know the history of the NHS when there have been some organisations that have been under immense financial challenge, and unfortunately the eye is taken off safety. If I could ask Chris, would just give the board assurance about what we are doing about understanding the safety implications of the turnaround work that we are leading at this moment.
Shall I make a start? Thank you, Chair, because I wanted to come in anyway. And really, despite the difficult messages that we hear on this, the exec team speaks as one voice with the patient at the centre of all the decisions that we're making. So whilst Mark might face the challenge of responsibility around the financial bit, we still work together as one to keep the patient at the centre of what we're doing. And what it means is wherever there are some really challenging decisions about what we can afford, all of those go through a robust process of quality impact assessment as well as equality impact assessment. We look to make robust, transparent, defensible decisions about how we make the very best use of every pound to keep our patients safe and to maintain the highest quality services out there. It is really difficult times, but I'm grateful that that exec team listens carefully indeed to keeping the patient at the centre of what we do with every decision that is made, and all of those are robustly governed to keep things safe.
And I guess that conversation is led by the clinicians. Yeah. Chris, is there anything further you wanted to add?
Yeah, I just wanted to say, other than what Rona's just mentioned, I mean, I work really closely with all the chief nurses of our organisations around ensuring safe staffing, so issues around our temporary staffing, bank rates, and we're linking with them regularly to assess that. We have our patient safety incident response framework where we would have reported any incidents related to safety or patient harm, and also through the Quality and Performance Committee through our place-based reports that is reported on a monthly basis around any areas of risk.
Thank you, Chris. Cathy?
Thank you. I suppose what I wanted to explain to board members who are not perhaps in the midst of the NHS and for members of the public who've joined us today and staff and public who might be watching online is why a system like ours is in this situation. So NHS England regionally and nationally will be tracking performance, financial spend, and we are an outlier in some areas of our spend, either with the trusts in our system, acute, community and mental health, or ourselves as an ICB. And these are the indicators for NHS England then seeing us as a system that needs to move into turnaround. PricewaterhouseCoopers are working with us. They are doing forensic, particularly from this week, assessment of spend, and they'll be working with us on this second phase of work from now till the end of August. We also, as Mark talked about, have Simon Worthington working with particularly chief finance officers ours, in the ICB and also across trusts in making sure that there is good understanding of what they call SIP schemes, so those efficiency programs that are taking place. What there also is, if your colleagues are interested, is something called the NHS England Oversight Framework, and that indicates that if certain indicators, performance, finance, or both together, are going in a certain direction, unfortunately in the wrong direction, then there are different interventions that come into place. And colleagues around the table who are part of trusts, such as Trish, will understand that, but it's to understand that it is evidence-based in moving into this turnaround situation. And it is working to ensure effective use of resources, but please also remember what my colleagues Rowan and Chris have talked about around safe staffing and also having our patients at the centre of our decision making. My last point is around table 4 on page 44 of the pack, which is the SIP schemes, the saving schemes that we need to undertake as an ICB. These are areas that my colleagues around the table on the senior team know that we have scrutiny and oversight, and I know our finance committee, ICB finance committee met yesterday, scrutinised this. There are a depth of plans in place, RAG rating as in looking at the risk management of them, an assessment on a regular basis, and we have something called the FCOG, which is a finance oversight group for the system with trusts and for ourselves as an ICB, and this is where we are tracking our delivery. And I'm grateful that where we are working on elements of care packages with our colleagues in local authority, we're having very robust conversations to make sure that we, as always, meet statutory requirements, but and we also meet the requirements of NHS England because we're in turnaround, such as centralised panels for decision making, but we are making sure that place, including social care and place leaders, are part of the decision making as well. So it's an exceptional situation at the moment, but there is a framework that sits there, and our colleagues who are in the Lancashire and South Cumbria system and in Greater Manchester system have gone through this turnaround experience as well, and it is all based on the evidence, the information that shows whether there are outliers or areas of concern, and these are very common methods used in the NHS. Thank you.
Thanks, Cathy. Really helpful. Mike, Chair of Finance Committee, report.
Can I just, second set of comments actually on that?
Oh, was it?
I had two sets of comments. I just wanted to turn our attention to the budgets we directly manage and control. And I echo Mark's comments around the work that's been done around package of care, including continuing healthcare. It seems like we're beginning to get control of that, so that's great news. I absolutely support that. The other two areas that we've got within our budgets still give us concern and carry risk. So prescribing is the first one. It was reported yesterday that we are behind where we should be in terms of cost improvement work. And I'm still not fully assured that we've got the right consistent incentive schemes down at primary care level, so there's a system of consequence in place for those who are actually taking the prescribing decisions. The delay in getting the information, which is 2 months or something, is completely incomprehensible in this modern day and age. So that's a further confounding factor really in terms of our ability to manage that budget. So there's a risk there in our direct budgets. And the final one, which is coming up fast on the rails, is the independent sector and in particular ADHD. Euphemistically, I'll say it's puzzling and concerning what's happening there. And I think there's a piece of work that we have to progress urgently. I think we'll have to do it in conjunction with other parts of the NHS. I'm sure this is not an isolated Cheshire and Merseyside problem. I'm sure nationally we're being shaken down here in some strange way. The quality of referrals and the pathways really do need to be reviewed to ensure that we can re-establish control in that area.
Thank you, Mike. Are we happy to move on to the report, Cathy?
I just wanted to invite my colleague Fiona very briefly to talk about prescribing and that work with primary care. And I also recognise, Mike, what you're saying about market management with the independent sector as well. So maybe briefly something from Mandy on that. I know we're going to go into more detail at another point, but I think it'd be helpful.
Thank you. So we recognise often early in the year the prescribing issues can be off target. There are a number of reasons, and I think we've got really good understanding of the reasons why we're off plan at the moment, some of which are out with the control of the ICB, so things like our category M drugs, category C drugs, concessions, that sort of thing. So we track that, and but that currently is a net cost pressure of 500k. But then there are other things that are within the control of the ICB. So, for example, tirzepatide spend being higher than we had assumed that it would be. We know that that is a national issue. It's not just our ICB that is struggling with that. But we do have a plan to get that back under control. And I think it's really interesting your point about the people holding the pen, not anymore, but the people holding the pen over the green prescriptions. We were talking yesterday about whether we think that they have enough of an understanding about the impact of the decisions that they make every day. So Rowan and I talked last night about a plan to put on some webinars or help them to understand the financial position a lot better. The point about incentive schemes, there is significant variation in the incentive schemes for GPs in prescribing across our patch. So we do need to address, there is a plan in place to address that variation. It's not just a prescribing issue, that one. It's a primary care commissioning and contracting issue, because these are contracts that are in place with practices, and to change a practice contract mid-year for some very small businesses is very significant. So we need to handle that with care, but we've definitely got a plan to do it.
Just wanted to invite Mandy to talk very briefly about market management for us, because this is an aspect of work which Mike references ADHD, but there are other areas of the market that we're looking into at the moment.
Thanks, Cathy. Obviously, we're going to cover this in detail, aren't we, during the private board discussion, and it's going to be picked up there. I suppose we've just got to be cautious that we don't confuse the two. So we have quite a considerable agenda to deliver in our system around our elective agenda. So just like we talk about urgent emergency care, we need to be thinking about those patients who remain on our waiting list, waiting for various operations. And at this moment in time, we've got some difficult decisions to make about how we absolutely maximise our independent care sector, because we can't do it without them at this moment in time until we sort out and resolve some of our strategic challenges, but also recognise actually where do we focus some of our immediate priorities and the taxpayers' pound on that independent sector capacity. In terms of market management, that is a much bigger conversation that we need to be working with our social care colleagues with as well. When we talk about market management, that is about how we use some of our non-NHS providers in our system. And we'll talk about that in great length in our private board, Cathy, about some of the difficult decisions we now need to make to help support some of that challenge. that Mike's rightfully raised.
Okay, thank you. I'm going to move us on to the report of the Finance Committee, and it's Mike.
Yeah, well, unsurprisingly, we focused on the topic of the financial position and the turnaround, so I won't dwell on that further. But there are a couple of other areas that just to reference procurement. So there's been a particular issue with the non-emergency patient transport service. We had the authority to proceed for a re-procurement, which means an extension of the existing arrangements, which is not ideal, but it needs must in terms of the decision that needed to be taken there. And we reviewed the risk management arrangements that are present within the ICB. Have to take questions on the report.
Thank you. Any questions for Mike? Thank you. Should we move on to integrated report, Anthony?
Thank you, Chair. I'll open up with a bit of context and get into some of the main headlines, but it's entirely open to all members of the board, many of whom partake in trying to deliver today's agenda extensively. So, I guess the context for us is that, we are working to ensure that the way in which we provide services is absolutely contained within our funded capacity. We had an initial discussion around beds earlier on in terms of escalation. We have the same discussion we've just touched on there in terms of how we are using escalation capacity in other areas, both within hospitals and out of hospitals for elective. And we are really trying hard to ensure that we deliver our objectives and our trajectories, but we do that in the most efficient and productive way that we can. Also within the context that no matter which touch point you look at, whether that be primary care, community care, mental health or hospital care, demand increases absolutely year on year. I can't see a single point of contact where I've seen any abatement in that this year. So in terms of some of the headlines, I think people will be very, very used to the format of the report, and obviously the detail around any of the areas that are off track is contained within the exceptions. But what I'd say in summary is, I think if we look at our A&E performance, it is marginally up on last year, albeit a dip has been seen in June. But I think, coming back to some of our earlier discussion, it's really pleasing to see that we have a much stronger ambulance handover performance than where we were this year, and particularly important given that everybody is gearing up to ensure that from the 1st of August we are working to a backstop of no more than 45 minutes, and that's a national agenda that's been brought forward 4 months. And our providers are really working hard, particularly with NWAS, to ensure that we can do that in an absolute safest way. I think playing back to Mandy's earlier points, if we look at the average days to discharge that you see within the papers, there's an initial improvement around that. It's really conscious that you need to recognise that indicator is for the patients that are not going home. So that's really an indication of how long patients stay in hospital after they are clinically ready for discharge and going into some form of social care setting. So early days, but a welcome change. But we absolutely recognise that there are other parts of the urgent care system, like 12-hour time in department, etc., which is not where we would hope to be. But that is part of what we're talking about later on this afternoon in how we're approaching urgent care improvement holistically, rather than just trying to pick off a single metric and put our efforts solely in that place. In terms of elective, whilst our overall RTT performance is now compliant with the planned trajectory, we recognise that there are individual sites within that, and that's being supported by the ICB and the provider collaborative to ensure solutions are achieved through mutual aid, and also the appropriate use of some of that centralised elective capacity we've got. But again, let's try and put as much emphasis on using the patient themselves through patient-initiated follow-ups, and also on theatre and outpatient productivity as well. A real drive that we will only reach that bridge by making some of the improvements there rather than just additional activity. Long waits have spiked at the end of March, and some of that is that real dichotomy of trying to balance within funded capacity and ensure that we don't use escalation rates for certain activities. We do have recovery plans in place to address by the end of Q2 They will be challenging, but that is, you know, an attainable target. We are being pushed harder on that by NHS England. That is slightly out of where they would like us to be. But again, we're having to make some really difficult decisions about balancing capacity, funding and patient safety within all of that. And we'll be presenting that to NHS England again next Tuesday. In terms of cancer, we maintain a great position in terms of the sentinel metrics of 62-day wait performance and 31-day decision to treat. We've got further to go in terms of faster diagnosis standards, but we certainly have a robust plan with our Cancer Alliance. We expect to actually achieve beyond the national ambition of 75% by the end of the year. We're aiming for 80 locally. And we will continue to update the board on progress against that. So if it's okay, Chairman, I'll conclude there, but happy to take any questions. Indeed, many of my colleagues who are involved in some of the more detail will as well.
Thanks, Anthony. Any questions or comments? Tony? Rowan?
Thanks for that, Anthony. We've been dealing with this in a lot of detail at Quality Performance Committee, and thank you for your expert briefing there. What my attention is drawn to is your charts. This is on page 94. You've got a chart there showing 4-hour waits from arrival and also 12-hour waits from arrival. What you've discussed so far is the ICB position here, but within that there is significant variance. So could you talk about how we're dealing with that variance?
So in terms of, you're absolutely right, the variation across our organisations against those two metrics is quite considerable, and predominantly the Cheshire system is more challenged in terms of the 4 and 12-hour performance. We are working, and we have improvement support specifically tailored to involvement both with the national teams in there, but we're also working with them to understand that in some cases there are some structural deficits, if you like. For instance, the East Cheshire, there's a very small same-day emergency care complement. We have received national funding for that. We are expanding that capacity, and that will allow us greater flow through the main department of East Cheshire, which we all know is a small, primarily rural setting, and it attracts an awful lot of patients into it as a result. So we've got targeted support, which we're supporting the Trust, and also in both the example of East Cheshire and the Countess of Chester, and coming back to, I guess, some of the points Cathy made around provider oversight, there is escalated concerns for both of those areas. They are subject to system oversight groups, which I chair along with Chris and Rowan, where we have a plan that we follow, which is about what is being done internally, what is being done with community providers, what support are we providing as a system to enable them to progress.
Rowan?
Thank you. And actually I wanted to pick up on East Cheshire as well with colleagues. Colleagues around this table have followed with considerable interest where we picked up, I think almost 2 years ago now, where our particular trust, East Cheshire Trust, had SHIMI, the summary hospital mortality indicator, that was significantly outlying where we expect it to be above that 95% confidence interval line. We've worked very closely with that trust. We've far better understood it. And I think it is the first time that I'm in a position to report to our board that the daylight has all but gone between their position of SHIMI indeed and that 95% confidence. The upper limit is 1.17 and they are now at 1.18. That has consistently reduced now over the months, even though we knew there was going to be a prolonged lag time with that. More than that, the slightly different ways of considering their mortality that introduces specifically frailty, the HSMR plus, remains within that 95% confidence. It's an organisation that's been on a considerable improvement journey and must stay on that journey indeed, not to take their eye off it. But I know the commitment that I had made to this board that we as a system would work with that provider to bring that SHIMI down. And as I say, we can barely get daylight between it now. There is further to go, and indeed where we can improve moving patients through that system, I think we'll continue to see the improvement, and it's testament to hard-working colleagues within that trust, the improvements that they have made. Thank you.
Thanks, Rowan, and good news. Ruth?
Thank you, Chair. I wanted to, I certainly acknowledge the huge pressure the services are under at the moment and the importance of making sure today's care is high quality and appropriate. But I just want to pick a few areas where, you know, the 10-year plan talks about shifting to prevention, really trying to get ahead of the level of need that and meeting those needs in the community. First of all, just a comment, just a huge congratulations on the smoking and pregnancy figures. We had a patient story earlier from Cheryl. I think we can't underestimate the investment that makes into the health of the children coming forward as a result of that effort to reduce smoking. And it's a testament to CHAMPS, the public health network, the public health directors, the clinicians who get behind this, and just shows what we can do as a system if we work collectively and really focus. So huge congratulations on that. Linked to that is another area where we know we can make a difference to people's health, and that's the data on hypertension and lipid management. We haven't really made any inroads into this for a long time. It seems to be roughly the same fixed numbers that come through. They're not at target. There's huge variation across the patch, and and I know the Q4 data are not included, and I know in previous years people have said there's a big push usually in Q4, but we still don't normally meet the targets. So this is really preventable work. You know, we can prevent heart disease. So question, in the narrative it says reduction in capacity and funding is offered as an explanation as why we're not meeting that target. So again, in the spirit of more prevention, a bit more explanation about what we're really going to achieve there. And then very briefly, and again, going back to the here and now, healthcare acquired infection. Again, we're trundling along. We were told maybe 6 months ago at least that there was a regional initiative. And I know the oversight of trusts is going to belong to the regional infrastructure in the future. It won't be our job, but really it'd be great to see that we've made some inroads into bringing down the healthcare acquired infection. And this is a real interplay between patient safety and cost, because it's harmful to people and it costs the system more when this happens. So just any comments on both of those areas, please?
Thanks. Who's going to give me a response on blood pressure? Ian?
Thank you for raising it. It is CVD prevention's a massive issue for us. It's one of the biggest drivers of mortality, costs, and we have struggled, and you can see the variance across the different places in that take-up. The references to the capacity do recognise that actually we've had vacancy freezers and intentions and capacity to drive all of that, and working with our practices in that space. We have still been able to secure work on what's called a CLEAR programme. We're only ICB in the Northwest, I think, who were successful in doing that. And that's starting that work now with some of our practices and CLEAR ambassadors to try and drive what changes, what things we can do to help that uptake happen, really. We have got a clear focus on that moving forwards, and welcome to bring that back or outside of here separately. But it does recognise that it is a challenge with some of the practices and the capacity to really drive that through. We have got the population health management, our enhanced case find. Until we've developed that, we are trying to ensure that our workforce knows how they can use that effectively and support practices in identifying those people who will benefit from hypertension case management too.
Thanks, Ian. And it'd be useful if that report comes back to the board, I think. You set out the timescale, and we'll see the progress, especially that issue about capacity. HCAIs?
Yeah, thank you. Thanks, Ruth. I mean, you have mentioned the review group that established. One other thing, I mean, we're really focusing on reduction of HCAIs, particularly in the Clostridium difficile and the E. coli. Something that we have recently introduced through our working closely with the CMAST and the Provider Collaborative is we've got a C. difficile improvement programme, and we've launched a a toolkit that all of our organisations have adapted and using. And what we're doing is some of our organisations are clearly doing better than others, so we're taking the learning from those organisations and sharing it across the system. So we're continuing to work with that, and I hope to see a reduction. Thank you.
No, is it on this topic? Yes, let's go ahead. Yeah.
So it was just to add to what Ian had said around the hypertension and cholesterol management. So the national contract, particularly around QOF, has been massively reduced. The targets have been reduced this year to be able to focus on CVD prevention. So I think there's a greater incentive there for practices to target those patients. And also at a PCN level, the PCN DES now covers also, there are targets within that to look at specifically around cholesterol management. I know that a lot of the pharmacy teams have been focusing on that and been contacting patients. So I would hope that with the additional focus on that we should see improved figures this year. Whether we can meet that target, whether it's a realistic target, is something else that could be debated. But I do hope that there should be an improvement this year on that.
Thanks, Diary. Helpful. Got Trish next.
Thank you, Chair. Just a couple of comments, and other people have made them, but just want to emphasise, just reflecting back as a leader of an organisation on the patch, that behind these numbers, of course, is a huge amount of work that goes on from staff. And actually, what you're hearing and what you're seeing in this is absolutely active and forensic, I would say, support and oversight from the teams across the patch to get to this place. It's a very challenging picture, but certainly, you know, I'd like to just say a big thanks to Anthony and to Mandy for the approach that they're taking with providers across Cheshire and Merseyside, because it's tough and it's challenging out there, and it continues to be. So there's a real story behind these numbers and a real improvement journey. I think the second thing, just to reflect again, and we've heard it through some updates this morning, is the recent publication by the National Quality Board on the focus, remaining focused on quality. Yourself, Chair, have mentioned it. It is really important in times of challenge and financial and sort of demand challenges that we continue to do that. What my reflections back are as a Chief Exec on the patch is that in all the meetings that I am involved in, that remains the top focus, and the challenge between each other and leaders across continues to be there and will continue to be there, and that assurance is important. I'll bet this is tough, you know, this is very tough both financially and demand. But what we're seeing is this real focus, this forensic focus on improvement, and you're starting to see that in the figures that you can see. So just some reflections back, Chair, as somebody on the patch and on the receiving end of it as such.
Thank you, Trish. It's really helpful to give that context. I've got Alison and then Mandy.
Hi, thank you, Chair. Thank you for the report, Anthony. I was going to go and just give a bit of a place perspective. So on page 90, and actually for the first time there's a sea of green in Knowsley on our urgent care performance. So that's our most deprived area. And yet we can see A&E waits, we can see delays coming down there. That is absolutely the work that is being done as a system, but that will include increased GP appointments that are enabling that to happen, and it will include the work with our social care colleagues, working absolutely with them to support people getting out of hospital. So I wanted to make that point. And then I think the really great way this is presented will be so important when we look to neighbourhood health, because we have to aggregate this data at a neighbourhood level now, and there are some indicators here. The blood pressure, the hypertension one that Ruth talked about might therefore be one of our sentinel indicators that Ian and others are working on some of that we start looking at for neighbourhood health and drive it at that level and understand from the people there why they're not coming forward, how can we really make this better for them. But I did want to highlight that sea of green. It's a rare treat in Knowsley to see that, and to thank everybody who's been part of that, so thank you.
Thanks, Alison. So yeah, it's really good to see that in the sea of green in Knowsley, and thank you for your thoughts about how we need to start thinking about neighbourhoods and how we measure impact. Got Mandy?
Sorry, Chair, I know you want to move us on. I just think it's a really important point, though, to pick up a couple of things in that performance report, because we talk a lot about urgent emergency care, don't we? But actually what the last few weeks have exposed is the importance to focus on the mental health as well as the physical health. And I do ask that the board does, in the future, maybe, you know, I know we're going to talk about mental health later on, but that real focus, because the variation across our system around our mental health support for our patients is quite considerable. And I know that that's something we're all quite passionate about. And when we talk about mental health, I refer to placing patients in out-of-area beds. We talk a lot about no criteria to reside, but actually our focus should equally be on those that are clinically ready for discharge too. I just want to pull out a couple of things. What's fascinating for me, being in the system now since April, is we have some fantastic examples of good work in our system. And I think, if anything, our focus now needs to be aligning with the great work that Anthony and the team are doing, is how do we now take the good areas and really adapt, adopt, spread at the scale we do. And we're starting to see some examples, and we'll be picking, no doubt, some of that up in the private board. The final bit I don't want to lose sight as well around, when we talk about electives, the 65-week, our challenge is huge as a system now. And it's lovely now to see, and it's important through the provider collaborative, etc., that real commitment now that we're working towards eliminating our 65 weeks by the end of August. And I think it's important that our patients also realise that is our aspiration, working with our colleagues to get there. Thank you.
Thanks, Mandy. And it's a really useful prompt, isn't it? This board before has talked about how do we know there's great practice happening somewhere in our patch, you know, whether it's in an organisation or in a place. How do we spread it? How do we get a learning system that drives that? I don't know, Fiona, I know you've got some really good thoughts on that, and we must return to that. And I think our new structure will help going forward. I've got one thing, and you know I champion children and young people. Ask it of you, Anthony. It's really disappointing to see that deterioration in long waiters for children. Now, I don't need to tell people a year is a long time in a child's life. Is that down to, what's that down to, Auntie? Is that capacity constraints because we were doing so well up until the end of March?
Yes, I think is the simple matter. I think at this point in time we are going through that transition period where we're trying to adjust to within our funded capacity baseline, even within some of our specialist children providers. There are certainly opportunities for greater theatre efficiency in some of our children's units. And there has been to date quite a reliance on additional escalation initiatives. And we just need to adjust back the focus to try and contain within our existing capacity. It is part of the recovery timescales that Mandy's just touched on there, albeit we're focusing on 52 weeks for children and 65 weeks for adults at this point in time. But you know, I see this as it's uncomfortable, but it's a transitional period to get us to a longer term solution for this.
Okay, so it's more than uncomfortable. I find it really disappointing that we've got this performance, and seeking to understand what our real capacity need is for children, I think is what you mean by long term, isn't it, Anthony? So let's get there quickly on that. Okay, I'm going to move on from this report. Tony, can I go to you as chair of Q&P?
Yes, thanks, Raj. Yes, just first of all, one thing to bring to the board's attention as an alert, it's the vaccination programme. And I won't dwell on this too long because I know there's a further report on this, but the committee noted that while the uptake of ICB providers is above regional and national levels, because that was only at less than 40%, there was considerable concern in the committee about this. What is commendable is the approach, the commissioning of insight work to actually identify why healthcare workers aren't coming forward for vaccinations, and getting down to some simple things like the lack of time, convenience, but some complex areas such as post-pandemic vaccine mistrust. this is really the way forward with this. So the numbers, although we are performing reasonably well against the rest of the country and regional, are still a very great concern. So I know we're going to hear some more about that later. We've mentioned quality a couple of times today, but particularly draw your attention to work that's been undertaken with Warrington and Halton hospitals by Chris's team. A number of areas of concern were identified in a desktop review, but again, what's particularly commendable is the very close working with that provider, with experts from Chris's team, particularly the central patients safety team. And what the briefing identifies is the trust has got some very explicit actions in place to tackle things like sepsis recognition and management, urology, breast surgery and gynecology. So again, what I would say is, as a personal view, what I think could be held by others, that the further away we move the monitoring of quality and safety up to a regional level, whether that's in terms of healthcare acquired infections or quality indicators, we don't want to lose that very close contact with our experts in place and with providers, because that's where the real difference is made. So again, the committee session in June covers a lot of this about close working relationships with providers. Thank you, Chair.
Thanks, Tony. Mike, Chair of Audit.
Thank you, Chair. The main item of business was around the final accounts, and we dealt with that at the meeting of 19th of June, so I won't dwell on that. There was a cyber security audit that took place on 13th of May, reviewing our performance against meeting 8 nationally set standards. It's been indicated to us by NHS England that it's not expected that we're going to meet all of these standards. They are gold standards. But the committee approved the recommendation that we submit the report of the outcome of that audit to NHS England. We reviewed the risk register. We've taken a risk off the register, that's G10, relating to the re-procurement of information governance services. We received the FOI report that highlighted 135 FOI requests, and also the subject access requests, of which we received 18.
Thank you.
To take questions.
We're happy to move on. Thank you. Erica, can I go to you, Chair of Prime Care Committee?
Yeah, sure. 2 points from me. One that we've already called off, so thank you to Kathy and to Fiona. You'll see the alert was around prescribing and the budget. When we had the last primary care, we didn't have the granular detail. Fiona's gone through its multiple issues and challenges. From primary care's point of view, it's looking at, do we understand why that's happening? Have we got plans in place? Have we got the resources? And when we have, we've got actions in a timely process. So it's to give assurance around that. The last primary care, we didn't have the detail.
Yeah.
Second point, very quickly, just want to acknowledge the work that Healthwatch has done. Later today, we're going to have the presentation from Louise. It's all around access, which is so important to all of our residents. They managed to speak to 7,000 people, and I think that it shows the value of that independent service. All that information has come back to us. It is going to go out to place, and it is informing what we do and how do we continue to try and progress with that. There are some small highlights, but there's still an awful lot to do on both GP access and dentist access as well. That's it. Thank you.
Thank you, Erica. Happy to move on. Tony, Remcom.
Thank you, Chair. Thank you. At the 11th of July meeting, we received a report updating on the publication of the new very senior management framework, which detailed new pay ranges for key BSM roles. We reviewed the paper and improved the use of the framework. It's got to be emphasised here, this is for future appointments. That was made very clear in the meeting. It does not apply to existing BSM appointments. We received a report in the same meeting about the annual pay award for VSMs of 3.25%. The committee, in considering this, decided not to apply the pay uplift for 2025-26 due to the ICB's significant financial challenges and the situation we're in with transformation, as Kathy has alluded to earlier, potential redundancies. So it was agreed that this was a deferral for 1 year, not that we reject the idea altogether. I think that's sufficient for me, Chair. Thank you.
Thank you. People happy to move on?
Can I just add something?
Go ahead. Yeah.
Thank you. I talked earlier about our model ICB and the restructure plans that we and all ICBs in the country need to make. We do have a task and finish group that is a group of chair, non-exec and some executive colleagues. But if we need to make any key decisions or have more formal oversight, we will go to the remuneration committee. So it's a governance point really, but to show that connection of something we've introduced as a new group, but it does connect to existing governance. Thank you.
Thanks, Cathy. Move on to my report from the Children's and Young People's Committee. You can see there's one item for alert, which is a request for £20,000 to be invested in improving our communication with young people, in particular people living in poverty. That's now going through the normal or the revised finance system for decision or not. Happy to take any questions. Thank you. I think Hilary.
Thank you. So this is a highlight report of the Shaping Care Together Joint Committee, and just as a reminder, this is a programme that's focused on improving urgent and emergency care for people across Southport, Formby, excuse me, and West Lancashire. So therefore it's a partnership programme supported by Mersey and West Lancs Teaching Hospital, Cheshire and Merseyside ICB, and NHS Lancashire and South Cumbria ICB. So the committee membership reflects that partnership. This is the meeting of the second committee. The first meeting was in shadow form, and this meeting was held in public in Ormskirk. And as you'll see from the minutes, the July meeting, we approved the pre-consultation business case and consultation plans that are now underpinning the public consultation on a range of options for urgent and emergency care across those geography. It's a 13-week consultation, and that went live on the 4th of July. And if you look on the respective website of all three organisations, you'll see that there's a really comprehensive programme of engagement for the public and stakeholders across various mediums, and some are online, some are virtual, and there's lots of surveys taking place as well. We'll obviously bring back the outputs of the consultation in due course. Thank you.
Thank you, Hilary. Happy to move on. Ruth?
Thank you. This is a report of the North West Specialised Services Joint Committee, which oversees decisions where the three ICBs need to work together, so it's a narrow set of the specialised commissioning choices. The alert relates to the adult critical care transport service. The selection was unsuccessful, and there are other complications in the other two ICBs. However, there's a rollover situation with regard to our service for the time being, and we'll come back to that in September as to the way forward on that service. The only other thing I'd pick out from the risks is that the team undertaking the work of specialised commissioning on behalf of us all is under stress because of the recruitment situation and the changes that are going across the system, both ICB and across the regional teams. There is a risk to some of the major programmes of change not progressing at the pace that we'd want to do, and we will be coming back to the neonatal intensive critical care service at our September meeting to get a revised timetable. It's important we carry on doing some of these major bits of review to ensure that we've got the best possible services, so it is a risk that we need to be aware of.
Thank you, Ruth. We're happy to move on. And Hilary, Women's Service. I think you're next on the Women's Hospital review. Is that not on there? Yeah.
The report was missed, wasn't put into the pack from our last committee. Matthew sent it by email yesterday, so it is available to the committee.
Okay, so it should be now included in the final pack. Are there any views or comments on it?
Sorry,
It's in the public domain and in the final pack now. So I'm just going to look to Matthew. Matthew, is it on our website now?
Yeah.
sorry, and I've just got it because sorry, I didn't read the final pack. I was looking at another pack. But yeah, minutes as read. We Fiona, you need to help me. Yeah, we've got a long list of options now that are still being worked through. And we looked at the programme. Sorry, I can't even remember. Yeah, so but Liverpool Foundation Trust are working on the programme plan. It's making good progress in terms of the short-term and medium-term options, but obviously we're looking at them at the longer-term options, still working on the long list.
Well done, I'm catching up. Fiona, is there anything further what you want to add?
Can you see on the agenda?
The only other thing that I would draw attention to, that the committee received the Prevention and Equity Population Profile Summary that had been done by Claire Baker, one of our public health colleagues, and it is attached with the papers that will be coming out, and it's just a very interesting and sobering read, really, that the vast majority of patients who use services at Liverpool Women's Hospital come from the most deprived and underrepresented communities, and it puts, we've all known that intuitively for quite a long time, but this gives us the numbers and the information behind it. So the committee had received that report as well. And the other thing to draw attention to, which I think is positive, is that on the programme risk register for on-site quality and safety today, the Women's Hospital team have made such good progress over the last 12 months in improving safety on site that the risk was reduced on the risk register.
Oh, good. I mean, just on that last point, given where we were 2 years ago, I think, where we were at really significant levels of risk for the quality and safety of care. I thank Hilary, Fiona for all that work, and obviously to our colleagues at Liverpool University Hospital.
Just to be clear, it was the staff at the Liverpool Women's.
Sure. Liverpool and the Women's, so really good stuff there.
And actually the staff at Loft as well, because the big difference that's improved safety on site is the collaborative working between the two organisations.
Yeah. So that's good stuff. Ruth?
Could I just say a very big thank you for the report on the equity profile and prevention profile. It's absolutely excellent. But I wanted to link it to the work that we'll consider later on neighbourhoods and our role generally going forward, that this is the sort of work that we need to see informing our design of services. And so just a real thank you to whoever did the work, and to make sure we learn from it and embed it in our other processes. Thank you.
Well said, Ruth. Good stuff. My thought was we should come back to this report as an exemplar of how we can inform that strategic intention going forward. Yeah? Good. Right. You can have a break.
Thank you.
Let's try and get back in 10 minutes, please. go back, I think, nearly.
Yep. That's where I'm going to
So where's Simon?
do you know it's Mike's birthday?
I didn't. Yeah. Oh, you did tell me.
Thank you, Chair. So this is the update on where we are with intensive assertive outreach. Just for the benefit of the public and those people not aware, many people who experience psychosis are already able to receive evidence-based care and treatment which enables them to recover from their episode and to be supported in continuing their daily lives. But some people struggle and need a bit of additional help and need access to evidence-based care and treatment. And this may be because core services aren't equipped at that time to meet their needs. Or it may be their impact, their symptoms is particularly acute and they need that additional support. So for this group of people, it's really critical that our services are able to respond to their needs, adapt their approach to engagement, provide continuity of care, which service users very much value, and have a range of treatment options. And these people can also be very vulnerable to harm from themselves and from others, and a very small number can relapse. And we have a duty to provide care and treatment in a way that meets the needs of this group. Now, an intensive and assertive outreach approach doesn't have to be a standalone team. It can be through dedicated provision in place within community mental health teams or other specialist services. So improving the care and treatment of individuals who require intensive and assertive approach from health services is a priority in Fit for the Future. Fit for the Future commits to 100% coverage in the next decade of this approach and these teams, and you have to search for that commitment, believe me, in the 116 pages or so, but the headline that's aligned to is improving and expanding our approach to mental health in terms of an urgent and emergency and crisis care lens. So members of the board will recall that guidance on this was published in July of last year. We had a template to complete and return by end of September last year, and we were asked to bring that template, that report, to the board, which we did in November, which provided an overview of the gaps in provision identified against the guidance. That report included an action plan outlining short-term actions with minimal resource implications, as well as potential longer-term actions which had resource implications. Since then, my colleagues in the mental health trusts in the mental health programme have worked with us around putting those short-term actions into place, and that's overseen by the Cheshire and Merseyside adult and older adult community mental health oversight group, as we're wrapping this very much into the community services approach. NHS England have also published draft personalised care guidance for those services, which further supports the work highlighted in the action plan and also in the homicide report into the murders by valdecocaine, in which 3 people and others were seriously injured in Nottingham in June of 2023. Now, while the review itself focused on the care of adults, and it's probably apposite at this time, it's a year on since Southport, we also felt that we needed to actually seek assurance around children and young people services, secure services, and also learning disability and autism services as well. And both trusts have presented the findings from the homicide review at their trust board, and indeed these action plans that we're presenting to you today. The initial version of the report has also been to Quality and Performance Committee. We have made changes to that. We are required to provide independent oversight and assurance needed to satisfy the NHS Patient Safety Incident Response Framework, hence it went to Quality and Performance. And that was the agreement that at the last board where this was presented, it would go there first for further work assurance and then come to the board. So we're asking that you endorse the updated action plan, noting the progress to date. A further request has been received to complete and return a review template by the 3rd of September, detailing a RAG-rated self-assessment. I'm convening a small panel involving our providers to take that forward. But 5 things I think are essentially at the heart of the ask today. A commitment to a multidisciplinary team approach, embedded in community response to support people who need additional support, that this absolutely connects to the reduction of crisis-based admissions and A&E attendances by people exhibiting extreme mental health need, that these services exhibit positive user feedback and engagement because they provide continuity of care and build upon therapeutic relationships. There's an opportunity to scale up what we have in terms of dual diagnosis and complex trauma responses particularly. And finally, whilst we absolutely acknowledge there are workforce and therefore resource challenges in this, and there is that commitment in the over the next 10 years to scale up to 100% coverage, and we don't know what future funding settlements may look like, this is ultimately about a redesign of the whole pathway with what we have to an extent, and therefore that looks at crisis response, crisis techs. It has to look at who is actually presenting in crisis, where there are alternatives to NHS services, particularly where people are presenting with crisis due to socio-economic circumstances, who may need debt advice, housing advice, etc. How do we work better with the sector around that? So we continue to work on that, on the consequences and mitigations. It is unusual for such action plans, as I said, to come to the board, but because of the high profile of the cases I've referred to and the need to get this right, our boards need to be cited on this, and both CWP and Merseycare's board are cited on this, and I thank them and colleagues within those organisations for getting us to where we are.
Thank you, Simon. It's a very informative report. Can I take questions and comments, people? Fiona?
Thank you, Chair. Thanks, Simon. This is really welcome. I'm going to put my GP hat on and just ask a question. So looking at the action plan, I can see and really welcome about the DNA policy. I think that's so important, and I can see that GPs will be informed of that, and there'll be an escalation process, because getting these patients back into connected to services rapidly is really important. But while patients are still actively under the care of the mental health team, I think it would be good to see more, and maybe it is there and just not in the paper, that the GPs are more involved and kept more informed while they're still under the care as well.
I'd agree, and I think we'll take that back into the working group about maintaining communication with general practitioners and other clinical professionals involved in the care.
We've got Trish and then Ruth.
Thank you very much, Chair, and thank you, Simon. Really welcome this report here. It's, as you say, a very important report for us to be looking at. A couple of points and questions, Simon. One, the importance of making sure now that we have a consistent health model across all places and localities, given that we've referred to the variation in mental health response both in this paper and in previous conversations with the board, and how we're going to make sure we do that, one. Two, we know from the reports that you've referred to the serious instance that lived experience and family voice and family input into service redesign is critical, and how are we going to make sure that happens. And then my last point is linked to Fiona's point about DNA. So people with a serious SMI, a serious mental health illness, who disengage, how we make sure we evaluate what's happening and why that is, to keep this a transformational process and a learning one that we keep moving with, and how important that's going to be. And then just lastly, we talk about gaps here in resource, which I understand that work that's going on, but fundamentally this is a cultural change in practice in the first instance, and I think we need to make sure we're dynamic and mature enough to understand that actually this gap may look very different when we start to think about cultural change and focus of teams that are already in practice, actually, Simon. Because this is a different approach, and it's not actually going to be about all new resource. So keeping that open I think is going to be important and responsible as we go forward.
Thank you, Trish. Sam, do you want to respond to those three?
Yeah, I'll work backwards because I agree with Trish. This is about a cultural change in practice, and it's about how services have to shift to adapt to the needs of people presenting to them. And mental health services have done that very successfully over the years. I will make sure that we consider about how we evaluate why people disengage. That has to be part of active case management, but also then how do we collect that in terms of a quality and learning perspective and continuous improvement for the services. In terms of lived experience and family voice, experts by experience are engaged in the design processes of both the trusts, and again we need to make sure that that's maintained. It is absolutely essential we do have a consistent health model across all localities for community and crisis response. That would include having a commonality around crisis lines, first response, crisis texts, availability of crisis cafes, etc. We don't have that at the moment. One of the pieces of work Mandy's asked me to bring together with colleagues is the mental health, in response to the mental health UEC plan, develop something ourselves. What's the timeline for getting there? But also we'll be looking in terms of the opportunity. We met yesterday twice about looking at the opportunities for that short-term transformation fund that Region are offering around improving clinically ready for discharge as a means of decompressing the system, but also looking ahead in terms of the other things that in Fit for the Future, mental health UEC, improved crisis response, wherever we got our gaps in our patch, and I think particularly Cheshire and Merseyside have those gaps around a mental health UEC response. So that's the consistent health model that we want to move towards.
Thank you, Simon. Ruth?
Just to pick up on that point about the headline measures we have about mental health urgent care, but actually what this action plan talks about is much more detailed redesign of pathways. So as we move more into the strategic commissioning role, it'd be really helpful to be clear what measures we're really going to focus on, including the user experience, carer experience, but also whether we are delivering the changes that are actually implicit and explicit in the requirement of the review. So that was a general point, more data and clarity about what we want as commissioners. There was just a specific question I had, which there are 2 points. Trust to review and amend policies to ensure did not attend is never a reason for discharge, and that's marked green. But immediately after it, it says trust will ensure that if it does happen, it's a never event, and that's marked as amber. So we've got the policy in place. We're not going to discharge people because they have DNA, but we haven't managed to make the never event requirements. It's still amber. So it seems very straightforward to identify, hopefully, a very small number. So I just wonder, it says it's in progress, but I just wanted a bit more explanation about why we've done one thing, but we haven't done the bit that would sort of be the assurance bit.
Sam, perhaps could I look to Trish? Could you give us a view on that one, Trish?
Clearly that's the intention, and when you talk about treating something as a never event, there's a whole process around that, Ruth, as you would understand. So both trusts are in the process of making that happen. So we are enacting it, but it's not quite complete, yes.
Can I ask when it's anticipated, because it will then start coming through our board reports?
I think we're only weeks away from this, Ruth.
Okay,
I think, you know, by the time you come to the next board, you'll start to see that coming through.
Okay, thank you. Paul?
Could I just ask, on page 169, P9, there's a sentence there, collaborative work is being undertaken to develop the workforce. Could I ask, are you talking to the higher education providers about the possibilities in that respect?
Yes, so we've had, unfortunately she leaves this week, we have a woman called Vicky Allen working with specifically on mental health workforce issues. So there's active engagement with academic institutions across the whole range of mental health programme.
Okay. So Simon, any concluding comments?
No, I'm happy to take on board the points made, the 7 or 8 points made, ensure that they're reflected going forward in the next iteration of the action plan.
Thank you, Simon. Cathy?
Thank you. Board colleagues, I just want to thank Simon for undertaking a number of aspects of his Senior Responsible Officer role for mental health for the ICB across the system, as well as being a place director for us. So he shared a report with you today. He shared how he's looking at mental health at UEC. And also I'm grateful to him for being involved in Section 117, that balancing act of statutory requirements being met, working in partnership across the NHS and with local authorities, as well as understanding the ways in which we need to spend public money effectively. So Simon is leading on a number of aspects at the moment, which I thought the board might be helpful for the board to hear about. So thank you, Simon.
Thank you, Cathy. So if I can move to the recommendations, then Simon, they're mostly about noting, and I won't go through those, but there is one ask of the to agree the frequency of updates. Is that where you're suggesting it should be a quarterly update, Simon?
Yes, please, Chair, but to go to quality and performance first, because that's the... As I said, it's unusual. It's because the national directive has been to bring it to board, but Q&P provide a really good point of assurance and challenge.
So, board happy to do that, Q&P, and then noting here. Yep, thank you. Thanks, Simon. So if we can go to the Neighbourhood Health Services. Claire, are you leading on this?
Thank you. Yes, I'm going to lead off and then hand over to Alison Lee, my colleague over there. So delighted to bring this agenda item to the board today. So neighbourhood health is one of the key priorities for Cheshire and Merseyside partners and for the NHS. Not just because it's one of our top 4 priorities that we signed off last in March in the annual delivery plan, not because it's in NHS England planning guidance for 25-26, not because it's in the 10-year health plan and delivers the all of the 3 government shifts, but I think it's because it's the right thing to do. And I think it's really important that we just start with that. This is about wrapping care around people locally, working with all of our community assets in an integrated way with and for our residents. And I think it's absolutely critical that this is, really, I know there are all the other pressures, but this can help us solve some of our other challenges. So it's really, really important. I think it's also important to say it's probably the oldest new show in town. We've had care communities, we've had localities, we've got primary care networks. This is an evolution of all of the things already in existence across all of our 9 local authority places, building on the brilliant multi-agency work with our statutory and voluntary and faith sectors, as well as our statutory health and care partners. We are not, when Alison presents the framework, this is not about imposing an NHS Cheshire and Merseyside model. It is about a sort of a single coordinated approach, but we do have to respond as ever as an NHS body to some national planning priorities, and they're highlighted in sections 4.3 and 4.4, but I'm not going to go into those because they're must-dos. We will do those, and we will use some of the work that Ian's leading on in terms of outcomes and metrics to sort of support that. We have 59 neighbourhood areas. We've carried out a baseline to see where we're up to. Alison's going to pick up all the points about the framework and the 10-year plan. But just the final point, there's a national implementation programme. Closing date is the 8th of August. I think we will have between maybe up to 7 or 8 of our places will put in a proposal to be sort of in that implementation programme. There are only going to be 42 across the country, so it's unlikely, just managing everyone's expectations, that all of them will be approved. But we will support and work with our places on this. So I'm now going to hand over to Alison to talk through the framework. Thank you.
Thank you, Claire.
Thank you for that introduction, Claire. That's really helpful. So I'm not going to talk to every slide. You'll be pleased to hear that has gone out with your papers. So hopefully everybody's cited on that. So a couple of bits that I wanted to pull out. I think Claire's already said this is very much an enabling role for us. It's part of our new function really as an ICB. It's going to be led at a place level And what I mean by that are the partners, the professionals and the people within those 9 boroughs, not just our place teams. It's got to be led at that level and then delivered at that neighbourhood level of 30 to 50,000 people. So it's a new role for us to enable this to happen. Some of the things that are happening now that I think are in the paper, but just to pull out, I think it's really interesting to see that some places are going with primary care network boundaries, but they are not always geographical. So some places are saying, no, we should actually be looking at the towns and the villages and the neighbourhoods where people live, and they are the footprints upon which this work will be done. So we can see differences emerging there. We can see repositioning of our place partnership boards as they become the engine room for this to be done at that borough-based level, where we have local authorities, we have the voluntary sector partners, we have the GPs on board, we have Health Watch, we have all the right partners around the table at that level. We have got here the really exciting opportunity of using our digital data into action programme, CIPHER, that enables us to spotlight on some of the cohorts of people where we can make the biggest difference. What we do need, though, and this is highlighted in the framework, is a much deeper engagement so that neighbourhood health, the new NHS, belongs to the people, as it says in the NHS Constitution. And we are on the surface of that at the moment. So this version of the framework is much clearer on the importance of doing this alongside the people who own these services locally, and that's one of the biggest shifts that it is aimed for in this work. Fiona's going to be very busy because we are going to talk here as well around that OD and culture change and learning that needs to come through this. I use it every time, so forgive me when I talk about this, but we have the quote in our heads where colleagues from Sefton say it was easier to find out what's going on in Alaska than it was in the rest of Cheshire and Merseyside. So for us to be able to become a learning organisation and to share that best practice just within Cheshire Mersey is still a challenge. And there is good practice in every one of our boroughs. So if we can share that, then we will be really, really a long way on this journey. The other bit, and Claire's referenced the national scheme that's underway, we've got to be really clear in that, the budgets that we are identifying as part of neighbourhood health. This is that shift from hospital to community, and that's a shift of budget so that people don't have to go up into hospital when they don't need to. So for us to be able to ring fence, I don't like the phrase, but I'll use it, out of hospital budgets, because they are the things that are going to enable this drive to happen. And of course the expectation on us is to grow the proportion of our budget that is directed towards those services. So they were a few bit more of the intro. I am not going to talk to every slide, so let me just pull out a few bits because I'm sure you as board member will have things that you want to pull out. Okay, I am going to really sort of, to me, pull out the 4 key bits of the framework. Now, we've drafted the framework. It's based on best practice nationally, some nudges toward international best practice, and it's been iterated through feedback we've had from those place partners in our 9 places and for a couple of workshops that we've led. So they've had lots of engagement on this to date. But it is there to establish a clear vision for what we mean by neighbourhood health services in Cheshire Mersey, so we can really clearly communicate that as widely as we need to. It is promoting consistency on some things, but also enabling that we'll have both different starting points and, to Ruth's point earlier, very different populations that we're actually delivering neighbourhood health for, but we are promoting a level of consistency in this framework. Also, and this is a very clear message both from many people who've worked on this, are we clear what success means for Cheshire Merseyside? There is a proposal within the frame that we need to start with a simple set of metrics, but broaden that out. And you'll see a phrase that was news to me from my public health colleagues of primordial prevention. So that was a new one to me. So the real wider determinants of health have got to be some of the things that we're measuring in this. But there is an expectation on us to start with things that are going to make a difference in year this year and enable us to have a better winter. So there's a starting point and there's an ambition in what success is going to look like. And within the framework, then, we've really got a roadmap for how we're going to develop this over the next year or so and into the 10-year plan. So Claire's already alluded that the 10-year plan, neighbourhood health is sprinkled within all of the chapters of the 10-year plan. I think really interestingly, when we go out and present on this, I think to the wider population, people always have said before the 10-year plan, well, where are the neighbourhood health centres going to be? People are expecting the buildings as part of this, and actually, you know what, that's in the 10-year plan. So starting with the places where we have the lowest life expectancy, we are now asked by government to set up these one-stop shops for patient care. Now, I think in some places we've got a really rich tapestry of buildings. We have one public estates working, but to actually name those very quickly, so this is where neighbourhood healthcare is going to be delivered, and then surrounding that there could be wider community hubs. But it's almost the first question I've always been asked by people is, where are the neighbourhood health centres? So that's the plan in and of itself, isn't it, is for us to be clear. Claire said at the minute we've got 59 neighbourhoods. That does about map to the 30 to 50,000 population. So planning to have a neighbourhood health centre in all of them is an enormous piece of work in and of itself. But interesting, that's the one thing that certainly elected members and public, when we talk to them in the 9 places, that's one of the first questions we get. There are lots of other things within the 10-year plan that are on that slide as well. So the vision, what we did was take what was written, and I asked AI to say, bring this down to a reading age of about 8. So to distill everything that is out there around neighbourhood health and try and make it as clear and simple as possible about what this means. We're not saying to every borough, to every neighbourhood, this is your vision, but it's tried to distill it to something that is clear and simple. So we have some consistency about how we are actually talking to people about this. So that's the proposed vision for neighbourhood health in Cheshire and Merseyside. We know, because some places are well on with this, they've got their own versions, they've developed with their people, with their politicians, with their partners, and we would absolutely respect that. But that's the vision that we're aiming for in Cheshire and Merseyside. We've also adapted this one from Liverpool. Again, each place, again, has slight nuances on this, but I think we need to be clear when we talk about neighbourhoods, we're meaning a specific geography, that's what that means. When we're talking about integrated neighbourhood teams, they are the teams we're expecting to be together, sitting alongside, working seamlessly in those neighbourhood health centres. There'll then be much wider multidisciplinary working, where you'll be pulling in people from specialist trust, you'll be pulling in people from all kinds of organisations to help around a specific group, but they won't all necessarily be based in those neighbourhood health centres. So it's pulling out from that those 3 different definitions, which are all part of neighbourhood health. I'm not going to go to the next ones. A lot of this is taken from the King's Fund, but it's really setting out the 3 different spheres of neighbourhood health, starting very much with the NHS, broadening into health and social care, and then that wider neighbourhood health of delivered by the people, for the people, with the people. You know, experiments I'd want to see there around the voluntary sector really leading some of that in some of our 59 neighbourhoods. If some are ready for that now, brilliant, let's crack on and enable them to do that. So they're the kind of 3 circles of neighbourhood health. Briefly going to stop here on this slide, if I may, Chair, which is our initial driver diagram. It sets out some of the principles by which we are developing neighbourhood health. It talks of the scope very clearly for this year. We're asked to start with NHS primary and community services. That is both physical and mental health. Over time, broadening that into other layers of services and groups coming into that. We're starting with that 30 to 50,000 population. We are expecting leadership and accountability for this at place and neighbourhood levels. To enable this to happen, and again, this is very much part of the guidance and the 10-year plan's ambition for the new NHS model, a really mature place, we would hope that you've got an identified lead provider to take this on within the place. We're not prescribing, and nor is the guidance who that provider might be. It might be a local authority, it might be a GP organisation, it might be an NHS trust. But each place is going to have to look at what works for them, what works for their population, who is best placed, to use that word again, to take on that lead provider role. So we'd expect that to develop over time, and certainly those of you who read some of the national commentary, they are not saying that all places are ready for that now. But that's an ambition that we relinquish our role in some of this, and it passes to the provider to take that on. I'll come back to impact in a moment. again, in developing this and through some of the consultation and engagement we've had to date, we've set out some of the key features of neighbourhood health. It has broadened from initial drafts that have gone out to people, recognising the importance of it being community-led, recognising the importance of being able to really describe improvements. I've called it narrative and numbers. We need hard metrics, but we need the narratives like the story we've had today that illustrate the benefits of neighbourhood working. We've got an emerging logic model that Ian and public health colleagues are leading on at the moment. I'm not expecting people to be able to read this, but it really shows some of the outputs and the outcomes that would build a really comprehensive database of impact for neighbourhood health. But again, it's very clear we need to start somewhere, agree a number of sentinel metrics that we work from, but the scale of the ambition is to have at that neighbourhood level indicators that go, as I say, from this new term to me, primordial prevention through primary, secondary and tertiary prevention, but it is very much a preventative model of neighbourhood health that we're aiming for here. The impact measures set out by, oh no, I've gone ahead, sorry, forgive me. So there are other impact models set out by NHS England that again we are built into that. Claire's already mentioned the National Neighbourhood Programme, very, very short timelines. It is a permissive application process, so we would be asked to endorse all of those. Local authorities would have to endorse, and where there is an elected mayor, for us, then we would expect that within the Liverpool City region, that explicit sign-off by the mayoral authority as well. Chair, I'll pause there because that's the framework in and of itself. There are some next steps on the final slide, and then there are recommendations within the paper, but I'll pause there for further comments, so thank you.
Okay. So I'll come to you in a sec, Rowan. I just wanted to say something which is, it's my error really, because in discussing this agenda item, I hadn't realised the scope of what you were presenting here today. And I'm going to seek opinions of the board here. We need to do what we need to do today, and I'll take guidance on what we have to drive through today. But I really think this should be discussed in public, but also the subject of a board timeout. The significance of this to our organisation over the next 10 years, it's hard to overstate that. So bear that in mind. Do not feel this is the only time we will discuss the vision, the framework that you've got. We'll get some initial thoughts, but we've got to spend quite a long time on this as a board, really challenging it, being clear on the outcomes that we're expecting and the how. So just bear that in mind, but I want to seek Claire and Cathy, give me some guidance about what do we need to do today, pending that we'll have a board development day. Then Rowan, Ruth, once Cathy's spoken.
Thank you. I want to give some context to this. So most ICBs, most health with their health and care system are putting some sort of framework together. So you can look at Sussex, you can look at Greater Manchester, you can look at West Yorkshire. So there is something that we need a starting point. And what Alison has shared with you and has been developed through a number of workshops of champions we've got across the system, and they're from primary care, public health, strategic authority, local authority, NHS, ICB, so, voluntary sector. There's this great group of champions who are at least trying to develop a basis of how we do this, so we've got some consistency. It helps us go for opportunities with Claire Fuller at a national level to get pioneer status. I love the fact the local authorities are all wanting this. I know particularly Sefton do at the moment. So there is something about just giving us a basis to get through this first phase. And what Alison has outlined to you is looking at different approaches, looking at King's Fund, for example. We're grateful to other ACBs who've shared their frameworks with us. I agree with you. This is a in development, iterative process, but I think what Claire, Alison, myself and others around the table are asking today, including with the voluntary sector, is can you support this framework as a basis for us to go forward? And this really helps us try and go for pioneer status to at least get one of our places, if not more, on that national radar.
Okay. Claire, did you want to come in before I bring the others in?
Excuse me, yes, so I think from a governance perspective, we're asking you to support the framework as is. I know there's been a lot of feedback. We've had more feedback, if I'm honest, from board members and NEDs and member partners than we have from some wider colleagues. So that's really helpful. But I think today it's about supporting and approving it as is. We'll use it as the template for systems to apply for the national programme. But this isn't a one-off. I think it was always a sort of a first draft, almost an iterative process, because this, for me, sets the vision for us as an organisation as we move forward as a strategic commissioner. So would welcome opportunity to have a much wider, longer, sort of deeper debate about it. But I think if we could approve it today, and then we'll come back.
Okay.
Thank you.
So I've got Rowan, Ruth and Ellen.
Thank you. Hugely welcomed, and clearly if A, this was easy, it had been done already. If B, there was a very straightforward, obvious best route to doing it, all of our neighbourhood stuff might already be organised in similar ways, and yet we know that a lot of this has previously been organic, and there's a big journey to go on here. So I guess it's both an offer and a plea. Colleagues will remember at last board we brought the Integrated Research and Innovation System paper that said we will turn the effort of our research partners towards neighbourhood health, because we need to support rapid cycles of learning, evaluation, making changes, doing something really robust. So that offer remains there, and the plea is that we capture some of that, and we've already got colleagues that we work with, like the Civic Health Innovation Lab at Liverpool University, led by Prof. Ian Buchan, that I think we should be referencing that wraparound of research and innovation in all of our applications, because it will, I think, provide even more assurance back to the centre that where they are investing in us, they invest in us as a learning system as well as a system that will deliver neighbourhood health. So it might be there's a task outside of here that we provide some consistent narrative for each of those applications about our commitment to learn through this and use our research capability. Thank you.
Thank you, Rowan. Ruth?
Thank you. It's very exciting to think that we might, for once, be able to get to the vision of a community-based neighbourhood health service. We've been trying for decades to do this. So I'm coming at it from a very positive sense. And this is a good start to the conversation. Now, I absolutely agree it's the start of a conversation that we can get going on this. I've been reflecting on why it's never really happened before. We've always reverted back to using hospitals as the basis of our healthcare system. So the ingredients I think we need to really build into at this stage is measurement of actual services, not just have we had the conversations, but what are we actually going to measure that says we're doing it, we are providing it, whether it's a preventive service or a treatment service. We've got to rethink our performance report in a way that enables us to say, what are we actually delivering in communities? But the thing that I think as part of our roadmap is missing, and that's not to hold it back at this stage, but to say we need to put resource to it, and that's the flow of money. Alison mentioned budgets, but it's way more than budgets. It's taking a strategic look at what are we spending now? Is it fairly distributed against the brilliant needs assessment that the women's services have had done, the equity assessment? How are we connecting all this to understand where we're going? Because the underlying issue, which we've surfaced for quite a few parts of the conversation today, is the deficit that we're in financially. So I know we're expected to have a service and financial framework for the next 3 years. So how does that connect with this? Because if we're not clear about that, we'll end up building extra things that we haven't actually got the resources to deliver. So I think it's crucial that there's a clear commitment in our roadmap that we do some strategic modelling, financial modelling, that we look at resource allocation, and they look at costing of services so that people can do a proper business case for transfer of services or a redesign of services. So there's a huge financial analysis capability that needs to underpin this so that we change the way we think about our resources. Thank you,
Ruth. Great points. Ellen?
Ruth has made some of the comments that I wanted to make. I really welcome this, and I know that voluntary community faith and social enterprise sector are well on with this, so really, really grateful for this plan, and I see this as the beginning of a story, and as it emerges, the narrative and the details and the funding will hopefully fall into place. I think there are some of the things that perhaps in the past have stopped this from moving as quickly as smoothly. One is, I think, that the concept of neighbourhood, a definition of neighbourhood is different from a concept of neighbourhood, and I think that I'm sure this work has already been done, but asking those real life people about what they think about a neighbourhood is. And I think just branding something as a neighbourhood thing probably won't work in that context. And it may be different in different places. But I know when I'm asked about neighbourhood, it would change my definition pretty much day on, day out. I think the other thing is that sometimes that notion of building then having neighbourhood spaces that are called neighbourhood spaces, it's, you know, that theory when town planners don't lay all the paths first, they wait to see where the paths the people use. There's something about that, using the spaces that are already well trodden, and whatever those spaces might, community spaces, informal or formal, informal or formal educational spaces, those sorts of things that are already part of a neighbourhood's day-to-day exploration of their geographical space. And I think in terms of the funding of this, once that model has been established, ensuring that whatever funding is available is able to be sustained over a significant period of time. I think our sector, my voluntary community, faith and social enterprise sector, has really suffered from not having those kind of embedded contracts that enable things to develop and significant learning to emerge. Because if this is a new endeavour, it's going to be hard to make it land quickly. But there are already learnings that we can draw on. So I think that the various previous experiments, but also just saying, well, this is going to be people-led, it's community-led, and therefore putting the power of that transformation in the hands of real-life people, I think is key to this.
Thank you, Ellen. And Tony?
Thanks, Raj. Just picking up on Claire's original point there, this has been, and Ruth, this is a long time coming. I think I can go back 25 years with this idea, and it's not happened for lots of reasons. This is probably the closest I've come to seeing a clarity, so it's really impressive. Picking up on your point, Raj, about the board having to be further engaged in this, strategic commissioning requires a clear vision to be set, first of all, and I think that's the board's responsibility to do that, but do it in some considerable detail as well, not just have a welcoming and warm feeling about this is all about neighbourhoods and community. Let's get into some of the detail, some of the tough detail. The best slide I can see from you, Alison, is the key features, the 12 elements there. But in each one of those, there's a monumental amount of work to be done. And organising that and planning it is the next level down. I think the board needs to set out its intentions and get a methodology around that. Just to look at, using data intelligence such as Southport, we know it's there, but using it differently is a challenge. The need for broader integration of all providers, pharmacy, dentistry and optometry. There's an obvious thing that's a benefit, but it's a huge task in itself. So each one of these 12 areas, I think, is going to need some detailed programme work. We were talking earlier on about resources. I don't think this is about money in this sense. It's about using our resources as strategic commissioner to deliver on these 12. So if I've got a vision, it's tied up in those 12 key features, and the next question though is, and how are we going to, and when are we going to deliver these? These are long-term programs of change, which is what's been lacking up till now. It was always a good idea, but nobody ever actually got into detail about exactly how are we going to do it. So I welcome it, but really the next piece of hard work is exactly how are we going to deliver those 12.
Thank you, Tony. I've got Adam next.
Yeah, just to echo some comments, but this is really exciting. This is exactly why I got involved in this all, so it's really good to see this. I think I welcome the inclusion. It's quite broad, especially for wider primary care in particular, which is obviously where I focus with my background. We do need that detail, the detail Tony spoke on. It's quite a complex area. I think the way people choose their preferred contractors for each of the types of primary care does differ. So I think the geographical spread can collide a little bit differently. So what I mean by that is people choose their doctor and a dentist typically based on where they live. They might choose their pharmacy and optician based on different factors, and we need to start understanding that and mapping it in, not just treating everything as a geographic boundary. Talking geography, I think the comments around PCN boundaries and Ellen's comments around mapping where people live and where they recognise it, absolutely critical. I do think there's actually a bit of appraisal to find out what we've got in each neighbourhood first as well. So that's mapping existing system and mapping our assets. That's going to be critical to understand all of it behind it. Just some other brief things. I loved the colourful vision slide. I think that was clear in simple language. I think that's going to be crucial as we help people navigate through these changes if we can make them come to pass. And there's some huge enabling factors, not least of all, which is IT and connectivity underpinning all of that. I think it's called out well in the plan or the framework as we've got now, but just cognizant front of mind, we need to bear that in mind. The other comment came out a little bit from Ruth. It's around growing the area. It's about being able to bring other capacity into play. And I think the comments on measurement are critical. This will need some commissioning of some sort and some movement of our resources. And I think in our current financial situation, that will of course mean stopping doing something else in a different way. I think if we don't measure how much resources, how much activity we're able to move close to people, into more services and into a variety of community healthcare settings, as well as the prevention agenda, that's probably where my head is that's the thing that will stop it being a theoretical shift and start it being actually a real effect on people's health, is that measurement and us being able to demonstrate, yes, we've moved work, we've moved resources, we've moved how people access our services. So I think that will all be critical for it.
Thanks, Adam. Mike?
Thanks. I really welcome this. It's fantastic to see. And it's nice to see that national policy is catching up here. I mean, this is, for me, an endorsement of national policy, not an endorsement of what we're doing, actually. So they're getting it right at national level. But as ever, I worry about something like this. If you look at broadly the rhetoric over the last 10, 20 years has been in this direction of travel, and yet the acute organisations have continued to increase their share of resources that come out of the NHS. So there's a big challenge that we've got to address here to make sure it's real, and we need the national policy support to do that. I worry about the physical estate capacity and quality. We don't want to do this on a shoestring, we want to get it right, so we've got to address that constraint. The organisational governance arrangements, it's boring stuff, but we've got to make sure we get the models right here to get everybody on board. It's a big programme of change has been mentioned, so we shouldn't underestimate the behavioural and cultural challenges and barriers that we'll have to overcome here. Plenty of people say they're supportive, but you know they've got there'll be a lot of vested interests that will have to be carefully managed and moved forward to ensure that we do this. And finally, the evidence base. I was pleased to see the reference to the evidence base here, because many people will say, oh, diseconomies of scale here, we shouldn't be doing it. But there's a really good evidence base for doing this, good international evidence base, and we should make sure that we pursue that and use that around the health economics of doing this.
Thanks, Mike. I've got Naomi next.
So yeah, just to echo what other people have said, I'm really excited about this. I think this is exactly the way that health has been trying to push for certainly the last 10 years. I think I really like Claire's term of this is an evolution. What I don't want to do is to completely kind of reinvent the wheel. There are so many good examples within Cheshire and Merseyside where this is already happening. South Sefton came and spoke to board and presented some of their community working. There are multiple other PCNs and other organisations who are already doing this. So I think what's vital to this is the asset mapping. And actually we get to think outside the box with this. I think previously there's been so much red tape around not being able to collaborate and not being able to work together. I think actually this has really opened the doors to be able to us allow to almost take a social prescribing, asset mapping approach to this. So to look at not just health resources, but local council, the likes of Millennium Centres, the likes of Face Centres that are already being used and already being accessed and already doing some of this work. What that then allows us to do is to be able to not just treat patients, but to actually find and prevent patients from becoming unwell. That will help with UEC, it will help across the wider system, but ultimately it will help our patients, our population to live a longer, healthier life. And I think that's, if that's not what we're all here for, then why are we here?
Thank you, Naomi. Del?
Thank you. Like everybody said, really welcome this. It's incredibly positive, and I think it will really make some marked impact on some of our wider population health issues and health inequalities. But a real plea that we don't start from scratch. There are things out there already. We already have neighbourhoods and neighbourhood models. One size won't fit all. So it is evolving, but every place will probably have something slightly different. And I think the trick here also will be to build on some of the other government initiatives, so the Best Family Start Hubs, the new Community Hub announcement, One Public Estate. So there's other things that we can tie into this to make sure we have a really good model. And I suppose a real plea, please involve elected members, residents and the leaders of the councils. They're really interested in this. They've had their own individual letters from government, so they want to know how the governance is going to apply in terms of choosing the areas. And if we can contain and liaise with them to make sure everyone's on the same page, I think it will help. And just a final quick question in terms of process. How will we be, I can see the framework and I think that will be really helpful, but what will be the decision-making route for deciding on what we're going to be putting forward in respect of those individual areas? Just interested in the governance around that. Thank you.
Could I just, you talk about the bids, the Pioneer bids? Yeah. Could I just quickly on the Pioneer bids?
Well, we'll put them all forward.
Yeah,
if they meet. So, I mean, we're proposing to put as many forward as want to be put forward. As Alison said, they need signatures by literally everybody, but that shows everyone's commitment. We won't be the final decision maker. That will be a national and regional panel. So we will sign off. I'm going to sign off on behalf of Kathy. Kathy's on leave, but it literally will be. They'll all go in whichever system wants to.
Del, did you want to come back?
Yeah, no, that's fine. I'm just wondering at place level, how do we get sign-off and ownership at place level?
As far as I know, well, each place team has assured me that the place partnership boards are where that is now going to be signed off. So if that's not acceptable in your place, then you are absolutely a part of that, aren't you, in Cheshire West, for example? But we would expect that endorsement to come through that place partnership board. Now, some place partnership boards have elected members, some don't, but they've all got their governance routes very clearly set out at that borough-based level, Dale. So that's where I'm expecting it to come from. But as Claire said, every organisation that is part of that then has to sign itself. The local authority, the trusts that are involved, the ICB, the GPs, all have to sign the bids individually as well as collectively.
Okay. I'm going to start to bring this to a close. I've got Ellen very quickly. Are you okay? Let me... Paul, very quickly.
A quick observation, Alison. There's a reference to workforce development, notwithstanding the logistics, which are going to be a challenge. Has anyone considered the educational paradigm needs to be thought through as well? I think functioning in a different type of space needs a different educational paradigm.
I mean, it absolutely does, doesn't it? And it will need that nationally, regionally, locally. So is any work specifically going on here now? No. Rowan's already emailing as we speak with some suggestions about how we move some of this forward, so thank you.
Hilary?
Mine's a quick suggestion about our narrative, and this relates to Chris Ham's work that was published, I think it was late 80s, saying that healthcare delivery starts in the streets, not around buildings. So it's about, I think our emphasis on that needs to be stronger. Yeah, just a suggestion. I could go on and on about that, about why, but it's something I learnt as a health visitor, so I think it might be useful. Thank you.
Okay, so I'm going to come to you. Sorry, I've got Cathy and then Claire, then Cathy to have a final. Just some comments from me. Firstly, it's just saying some things. I think we should be seeing some synergies from All Together Fairer in this. It's implicit, but let's pull it out. Like Hilary, let's not focus in on the buildings. That's the wrong starting point. They should be a part of the solution as opposed to being leading the solution. And what's this other thing? The other thing I've put down in there is the importance of true community engagement, where the communities are actually part of the decision-making process and not in a much better way than we're doing, and whether that's through the democratic accountabilities that some organisations have got or others. Final comment from me is just about the vision statement. I looked at it for a while, and I think I don't like make healthcare better. That's just my personal opinion, because this is more than healthcare. And so, but the importance of the vision, what I'm really doing is trying to make clear the importance of the vision statement, because that's the single unifying point for all our organisations and our partnerships. So I know this is work in progress. We'll have another go, a number of other goes at it. Claire?
So I suppose, first of all, thank you. I think that's been one of the most enjoyable agenda items that I've presented and been part of, in terms of the energy and the enthusiasm. Although I was a bit nervous beforehand, I think it's been really good. So thank you for everyone's contributions, which is what Alison and I wanted. This has to be completely organisationally led and owned, and I think it's really important. And thank you for suggesting a sort of a more deep dive development session. So just beware, that'll be in your diaries before you know it. So be careful what you wish for on that. So, this is a moment in time, but I think it's a pivotal moment in time for the NHS and for the ICB, and I think we need to grasp it. With everything going on, all the challenges that we've talked about so far today, and I'm sure we'll talk about in private as well, we have an opportunity, I think, through our 26/7 commissioning intentions to signal that shift and use this framework and this area of work to do that. It will inform and underpin any longer-term service and financial plan. It has to, because if we don't get this right, I think we're really going to struggle as a system, as an organisation. And clearly we have the enthusiasm and passion to do that. So thank you to everybody who's contributed. I think just a couple of things. In terms of neighbourhood health centres, I agree, let's not get hung up on a building. I think, neighbourhood health is much more than asset buildings. And let's not just think of an NHS building either. You can put a badge on lots of places. In terms of engagement with wider stakeholders, Cathy and I were with the Liverpool City Region Chief Execs last week. There are meetings tomorrow with Cheshire and Warrington. There's the joint OSC tomorrow. So we are continually engaging and with senior and anybody really on this. So just thank you, and we'll keep working. And thanks to Alison. I think we sort of doubling up with this, and with Laura from Cheshire West as well. So thank you.
Cathy?
Thank you. You have to manage our enthusiasm on this, Raj, because we're so excited about this. But just referencing that meeting that Claire and I went to, because someone said, the Chief Executive of a local authority in Liverpool City Region said to me, why is it different this time? And actually, It's in the planning guidance for NHS, so every part of the NHS has to deliver this in an NHS way, and it is also in the 10-year plan. But also, as colleagues have said around the table, this already exists. If you go to Bootle Shopping Centre, it's already starting to happen. So I think we have to give credit to the colleagues in working in health and care across our patch who've been doing this for years and make it happen without the money, without the guidance, without a strategy. And what we're doing is supporting and celebrating that, as well as trying to build the best practice elsewhere. There are two risks and opportunities, I think particularly I can see. If you look at the logic model, and I'm grateful to Public Health responding to my request on this, where we are going to measure outputs and outcomes are not in typical NHS England targets in any way. They are in really different ways. We're going to need to start looking at fuel poverty, bed poverty, food poverty issues. We are going to have to work even further on health and housing and health and work. And I know we've got some good foundations on health and housing. It also means we will commission, and Claire's referenced this, in a completely different way from April next year. And that means our trust providers who have worked in a set-piece way for a number of years, we're going to have to take them with us on the give and take on that commissioning, and commission in different ways. And Claire Fuller, who is leading this nationally, who's a GP herself, is really encouraging different models of neighbourhood healthcare. And we've got a negotiation, but we're going to have to do a completely different way of commissioning over the next 3 years, but we can't start from the 1st of April next year. And therefore your point on board development is really valid, that this is our theme, this is on our agenda for every board meeting. So Claire, you'll have fun every time on this, but also in our board development session. But please, could we just begin here, because we're building on good practice in our system, and we're building on good practice that we can see both from research like the King's Fund, but also that we can see in other systems in this country and other countries as well. Thank you.
Thank you, Kathy, and well said. So I'll come to the recommendation, which is to note that this is work in progress or draft. The board, seeking the board's view on that. I can see everybody nodding, nobody saying no, so Claire, we can go ahead with that. I'm just going to say these few words. This is a really interesting issue from this perspective. We have got lots and lots of assets to build from. But at least in the NHS, if this doesn't feel like a seismic change and a seismic shift, we won't have done the job.
Exactly.
And the other question for me is, or interesting fact is, where should leadership lie for neighbourhoods? You know, again, if we do what the NHS always does, a very parental child, in both in terms of our partnership relationships as well as with communities, it ain't going to work. So understanding some of those cultural dynamics is just as important to success as having, you know, some beautiful delivery diagrams and whatever. But great, thank you for that enthusiasm. It's really, really important to us. So we'll go on to winter planning. It's pretty straightforward, this paper, I think.
I think so, Chair. I think it's, you know, it could arguably be a plan for a plan, couldn't it, the paper?
Yeah,
but I think what I would like to draw out is, you know, that the content of the paper is heavily drawn from the NHS winter planning guidance and assurance regime. And it would be easy to interpret that this is something that has gone to mental and acute trusts to respond, and then it talks about what the ICB will do in terms of stewardship. That absolutely is not the way in which we will be approaching the winter planning process. We will be using the plans and have been using the plans that have been built up from each of the 5 UEC localities, drawing heavily on the reliance of the already developed plan and incorporating system partners throughout that. We have developed and I've got voluntary subject matter experts that have been there across the system, and the next steps is we've had that first cut of plans already from our partners and shared them with NHS England. Good evidence of learning from last year, good recognition of the critical incidences that we faced last year, good evidence of the realities of the landscape around resources this year. You know, last year was the first year that no additional winter plan funding came, and there was an absolute recognition that transition has happened. So as I say, something will come back to board at the end of September for your wider discussion, the full content of the plans, and there'll be an ask whether or not you can provide a board assurance statement in terms of the onward submission. You can see in the next steps what we're doing over the next couple of months. It's important that we perform our own stress testing ahead of an NHSE-led winter stress-taking exercise that will take place in September. But as I say, pretty self-explanatory, but I think it's got the uniform buy-in from all our partners thus far.
Thanks, Anthony. Are there any critical questions, Cathy?
Just want to say thanks to colleagues working on this. We're building on the 5 locality areas. We really want to work with the provider collaborative, as we've done in previous years, but building further. And I think that's one of the things for me in coming in new is just making sure that we connect our plans, locality and trust, even better this year. As also, there are a number of offers from regional and national colleagues that we need to take on, but thanks to Anthony for putting this together.
Thank you, Cathy. So I'm going to move us. Have you got your hand up now?
I have,
Alison?
I have very, very quickly. The first thing that Neighbourhood Health should be doing this year is addressing this agenda. Yes. So the guidance for 25-26 is to know by neighbourhood your A&E attendance rate, your admission to care homes, your no criteria to reside, because all of the partners can actually galvanise around this plan this year as well. Yep. So while some of that longer term is sorted, there's an immediate ask of the brilliant neighbourhoods we already have to focus on this. I just wanted to make that link, Raj.
Oh, well said, thanks, Alison. Okay, I'm going to move us on. So paper's there for noting, and everybody's noted it. Ian?
Brill, thank you. So in your packs on page 212, you'll have a joint paper from both myself and Fiona around seasonal vaccination. You will remember from previous board meetings, we had quite a passionate discussion around the impact of respiratory illnesses, major incidents declared, and the subsequent decline in staff vaccination levels in that. Julie Kelly from the ICB has been leading a significant research and insight exercise across our system. It's had over 1,500 staff take part, and we're grateful also to leaders around the board and access to their teams and inputting into that. There's a full report we can share with partners as well, obviously to keep brevity of the pack small, it's not within that, but Julie's just going to go through some of the key themes, insights and recommendations with us now moving forward, if that's okay.
Welcome, Julie.
Can you hear me?
Yes.
Brilliant, thank you. So thank you for the opportunity to come and talk to you today. Like Ian said, I'm just going to whiz you through some of the key points that are in the paper. And I'm going to start by saying something which seems really, really obvious. But seasonal vaccinations can save lives and keep communities healthier, and I think we've forgotten some of that. They protect individuals from illness, they significantly reduce their likelihood of infection, but something we've forgotten is they massively reduce the severity of illness if we do become unwell. And I think we've really forgotten those messages. They help to protect vulnerable populations, they can help to reduce pressure on the health service, but they also keep the workforce well and mean that we're able to still function as a community and health service during the winter. We're going to be looking shortly at the key findings of the insight work, which we commissioned around the same time, actually, that the chair asked if a paper could come in the future to look at what we could do to collectively improve, in particular, healthcare worker uptake. So it's a really great opportunity because it also ties in with some of the wider winter planning that Anthony's just been talking about. So as per the slide, at the March board, the chair asked for an update, and we've undertaken extensive insight work. We commissioned an organisation called ICE Create, who are experts in insight, and they interviewed and involved 1,500 healthcare workers, predominantly within trusts, within NHS trusts, but when I spoke to a number of other colleagues at Quality and Performance Committee, I'm very grateful earlier for Tony for mentioning the work. A number of our colleagues in QPC said it would be great if we could also include colleagues from primary care, so I spoke to Naomi, and we also included some domiciliary staff as well, because we know that it's really, really important for us to be protecting staff who work in social care as well. Very, very grateful to both Naomi and to Anne, both as board members, but also as GPs, and Anne is also going to give me a slot with the chief execs as part of her role leading CMAST, which is great. So the key findings and the recommendations. So within your pack, I've described how the numbers have starkly reduced. And this slide quite powerfully shows, and apologies, this particular slide wasn't in the pack, but we can circulate it. If you look at the top, it gives the healthcare worker uptake rate in 2019-2020. And in Cheshire and Merseyside at that time, in healthcare workers, it was 82.5%. So, 4 out of every 5 of our healthcare workers were vaccinated for flu, which was brilliant. And then if you look to 24-25, that dropped to 41.4%. So it's halved. And on the left-hand side, you won't be able to see, it's far too small. But it just highlights, as Ian said earlier, the number of multiple hospitals that declared critical incidents on our patch. And whilst NHS England have said that we can't undertake an analysis of sheer cause and effect in relation to trust, respiratory illness supported by staff and healthcare worker uptake rates, we know that when rates go down in the community, it has a direct effect. It has a direct effect on patients and on our staff. And last winter, we saw really high levels of flu, COVID and RSV. So we felt it was really, really important to try and get under the skin of why folk are not taking up their vaccination offer. This isn't just about access, it's about attitude, it's about culture, it's about leadership, and that's why we commission that insight work. If you can see on the slide here, we give a list of all of our trusts. And our poorest performance was in the 30s, and our highest performance was only in the 50s. So we have an awful long way to go. What's really encouraging is within the UEC plans for this year, there is an explicit reference that every trust has to, as a minimum, commit to at least a 5% increase on last year. However, we are working with a number of our trusts to actually say, we're expecting you to have a stretch target. And the great thing is that, like Anthony said earlier, there are a number of subject matter experts who are reviewing all of the trust plans. I've had a look at the initial cuts in relation to vaccination, and I'm really pleased that quite a number of them have included stretch targets, and a number of them have also said they want to develop plans that are based on the findings of this research, which is fantastic. As I say, we're meeting with our chief exec colleagues later on this year. I've already met, as part of the UBC planning work, with a number of our trusts, and we've secured their commitment to really acting on the insight work. This slide here just shows very, very briefly that uptake varies by setting. So it's highest in the acute and specialist trusts, but uptake is lowest in care homes and within social care. And what's really, really interesting as well, and I am going to single out Merseycare here, Trish, when we've spoken to colleagues from Merseycare, they've advised that this year they've had a real recruitment drive, and a lot more of their staff are younger. So they know that there needs to be some very focused discussions with the views of younger people in relation to vaccination uptake, and they've actually included that as part of the planning for this year. So this just demonstrates that we can't just lump everybody together into one big homogenous group. The views of general practice are different to dom care, are different to acutes, are different to mental health services. You're not going to be able to read this, I'm afraid. They're the key findings. And I guess what I'm going to draw your attention to are the key recommendations, which are on the next page. So the key recommendations from the insight work were that we need to really focus on increasing capability, increasing opportunity, and increasing the motivation for staff to want to get vaccinated in the first place. In relation to increasing capability, there was something about providing really clear and credible information to people. There's an awful lot of mistrust in relation to the information that folk were given during COVID. And as Tony mentioned before, a lot of the insight work referenced that real COVID fatigue that people have. People got sick of constantly being asked to be vaccinated, but didn't always feel like they were being equipped with the facts. There was something about us addressing misconceptions and knowledge gaps and beginning to have a more honest conversation about the protection of individuals, but also what some of our staff came back and said to us was, don't keep telling us this is about protecting patients. We know we need to protect our patients. But because we're with our patients all of the time, we know that that exposure means that if we're not vaccinated, we could become unwell and then pass something on to our loved ones. And we don't really explore those messages as much. There was something as well about increasing opportunity for vaccination. So something that Anne really, so passionate, Anne, because I remember when you were the chief exec at Whiston, and you a really laser sharp focus, for the months throughout the flu campaign. You talked about the importance of speaking to your directors, making sure that there was weekly information in relation to how many staff had been vaccinated. There's something as well about not just having vaccination clinics in the daytime, because then we're going to miss our evening staff. We're going to miss staff when they end a shift and start another one. And that seems really obvious, but they're the small things that can make a massive difference. And also there's something about increasing motivation, emphasising autonomy. People want to feel that vaccination is something that they want for themselves and for their families. And it shouldn't feel that it's forced. And we need to remember at one point during the COVID campaign, potentially at one point there was something called VCOD, which was going to be vaccination as a condition of deployment. And if you remember, that was pulled, I think, a matter of days before it was due to come in. And there were quite a lot of people who we interviewed who said, this isn't really about me not wanting the vaccine. It's actually the fact that it feels like I'm being forced. I feel like you've taken my choice away. We've talked a lot today about the importance of listening to people. And I've included this slide because I think it really beautifully illustrates the importance of having compassionate conversations with people. And this was a line manager from Warrington and Halton Hospital. And she said, I've had one staff member who was very closely affected by somebody that passed away with COVID, and I didn't think she was going to have a vaccine this year. And I just talked through the benefits of having it, discussing the dangers of not having it and the downsides, and she got it in the end. And it really surprised me that somebody's attitude could change when they were so closely affected. You don't realise how easy it is to forget, and I think you just need to recall the reasons why they did take it in the first place. It was just gentle reminders and talking it through. There wasn't any force about it at all. Everybody in my team then ended up getting the COVID vaccine. And there's something about just having that compassionate conversation. Small things like somebody having a cuppa and a biscuit afterwards and thanking them and telling you that you value them and you value their contribution. So in conclusion, the board's asked to endorse our need for a coordinated and system-wide response, endorse our NHS providers to develop staff vac plans based on our insight work and really encouraging early signs if they said they will, and approve the board receiving regular flu vaccination uptake reporting throughout the season. Thank you, Chair.
Thank you, Julie. Really well presented and some really deep insights. I'm going to go to Mike and then Naomi. Ruth.
Hi, Julie. So, brilliant. And I think you're right. It's generational. It's by profession. I've certainly been on a ward late last year where literally the matron came up to us and said, we're an anti-vax ward. We're not interested. So I think what I was going to say is I think your analysis is right. I think one of the key influences that will really help are trade unions, actually, and local trade union reps, particularly. I'm obviously talking in terms of trusts, but they're a really good ally in terms of this, because if they're on board with it and they can get their local reps, they're often the natural leaders in those places where we perhaps are most disconnected from. Does that make sense?
That's really helpful, Mike, and actually something I didn't feed back. When I went through the plans that have already come in so far that Anthony referenced earlier, I was really quite surprised because we've asked for all of them to nominate an executive lead, and I expected most of them to be chief nurses or directors of nursing, but about half of them were their chief people officers. So I actually took an action to myself to pick that up with you, Mike, because I think there's something about a multi-pronged approach. Rowan's already had a conversation with the medical directors. We know that Raj, you've already had conversations with chairs. But there is something about picking up trade union and the importance of the chief people team. So we'll pick that up, Mike. Thank you.
Thank you, Mike. Naomi?
So it was really good working with Julie actually, because it helped me to look at, even just within our practice, what are our policies, what are our procedures around vaccination. Now CQC does have guidance for practices that they should keep a note of the vaccination rates within staff, but actually there's no consistency across general practice. There's no current guidance on how that is done or how that is managed. So it's actually really, really difficult for Julie to be able to assess what the vaccination rates are of our primary care staff, and that's not just within general practice but across all 4 provider groups. So that's something that actually we Julie said that we're going to look at. So how do we look at being able to get that data and being able to impact the vaccination rates within primary care? I think the second thing to note is that so Adam did just ask whether COVID vaccination will no longer be provided for healthcare staff this year. Now, just to say, I lost my dad to COVID 4 years ago. So you might think that I'd be really pushing for COVID to be a part of the vaccinations for healthcare staff. Actually, I think that COVID has reduced the rates of vaccination across the board because of the hesitancy, because of the anti-vax stance. Now, I wonder whether actually, and I think it'll be interesting to see whether now that we've taken COVID out, whether people will actually be more inclined to get a flu. Because some of the feedback that I had was, if I go and get my flu, they'll make me get my COVID. And actually that's not the case at all, but it made people more wary of flu vaccine. So I think it'll be interesting to see this time next year what were the vaccination rates like, and have they gone up now that have the flu vaccination rates gone up now that we've taken COVID out for healthcare staff?
Thanks, Naomi.
And Naomi, can I come back with that, Chair, please? Because one of the findings was very quickly. One of the findings was folk trusted the flu vaccine more because it had been around longer.
Yeah, really good point. And ask people to be brief, Ruth.
Well, first of all, thank you for the report. Comprehensive view. Some of it's not new. We know easy access and so on. There clearly has been a attitudinal shift as well, which I really appreciate the way you've presented it, Julie. Very briefly, when we had a big push, I think it must be probably 10 or 15 years ago, and got to the really high levels of uptake of flu vaccination, it was the HR teams that led the work in partnership with the clinical leaders who really got behind it as well. So I think that's really, what we're really trying to create here is a large-scale change process. So we need to really engage a wide range of possibilities. My question specific, don't need to answer it now, but in the list of providers, you don't mention the North West Ambulance Service. And my recollection, when we saw the data, they were by far the lowest uptake. So I just want to double check that they are included in the work, because they're a crucial part of our urgent care system.
Hilary?
Yeah, quickly, I've just checked again how many people are working in our social care sector. 82,000 across Cheshire and Merseyside. I looked at it last night, just checked it to think, that's a huge amount of staff. Is there anything we can do? I mean, they are working in services that we commission and co-commission, as well as the partnership we need. Is there anything we can do to accelerate our intervention with that group of staff? National research tells us that hesitancy is higher for bank and agency staff. Have we looked at those in terms of what we can do with our agency providers in particular? And also, reticence is higher in our lower paid graded staff as well. And that is the section of staff where we have more diversity. And it's no surprise that I'm going to talk about next. Because national research also tell us that the cultural barriers and the sensitivity issues for some cultural communities are quite large in terms of historical ways that we've tried to influence their uptake before, but also some faith-based issues as well. And these are the issues that these communities find difficult to talk to. So as well as doing our own behavioural insight work, which is good, I really want us to respect that research and our curiosity follow that and have deeper conversations in terms of how can we co-create solutions with these these other vulnerable sections of our workforce that are meaningful for them, that they feel empowered to co-create solutions with us. And then, in addition to our champions, just a plea that we have a diversity mix. Our mix of champions are as diverse as the population we're trying to protect. Thank you.
Julie, I'm going to come back to you at the end for some further comments. So let's hear. Del, did you want to add anything further?
Just very quickly, can I ask that this presentation goes to the Cheshire and Mersey DAS network, because I think there's almost a call for action here, because those figures are really stark. But if the DASs get behind it and maybe work with you on a strategy, because we've got hundreds and hundreds of independent commission providers, so it might just be a starting point. Thank you.
Thank you. Adam?
Yeah, there's something in there about access. We did some work up in the North East with Newcastle University Hospitals Trust, who they really struggled with some staff who either didn't routinely work at the trust premise, so the MISA clinics, or they had some weird and wonderful shift patterns. And actually there's some solutions in that zone that involve community pharmacy, but there's some other options in there as well that make sure, A, we give them access to the vaccine as well, and the influence and the encouragement, but also we report back into the trust figures in the right way as well. So if it's something you wanted to work up, I'm more than happy to describe what happened there and work that up with you.
Thank you.
Thanks for that offer, Adam. I've got Trish and then Anne and then Rowan. I'm going to close it then.
Thank you, Chair, and thanks, Julie. Really welcome this, welcome the insights and recognise the insights in the report. And I think the recommendations are very clear and need proven, personally. A couple of things I want to say. One, always disappointed when I see those figures for Merseycare being so low, despite a real push in the organisation and despite ensuring that the 10 high-impact interventions happen. But the feedback we get absolutely mirrors the insights that Julie has described here of the reasons why. And two things I just want to highlight in the report are really important. One is the local communication and how important that is. And the majority of our staff live and work locally and from local communities. And I think that's maybe a game changer this year. And I hope we're really going to work with Julie and the team on that. And the second is the staff-on-staff influence. In terms of uptake. So I think they're two really important things to pull out, Chair, and but absolutely support the work that's going on here.
Thank you, Trish. Got Anne and then finally Rowan.
The reason why Julie sought my opinion on the subject was because the trust I was running actually once had the absolutely highest staff vaccination rate for flu at the time, because probably before COVID, I think, probably. And was asking me what did we do to do that? Was there incentives? And there weren't. It was all about top-level leadership, nagging, just going on and on about it personally, as the leader. It was about making sure it was accessible, and that 24/7 thing when you're in a 24/7 business needs to be there. And it's about the way the messages were presented. And of course, as we've moved on and things different and we're in a much worse situation now, I do think we need to fight social media with social media, because a lot of this vaccine hesitation or scepticism is fueled on social media, isn't it? And we talk about newer staff, younger staff. The people we need to engage with probably are that generation that do engage a lot with social media. So, I mean, we found making films of, like almost patient stories, but whatever, we made lots of films about stuff and why you needed to be vaccinated and stories about it. And I do think one of the things we need to do is really get on top of that and find the best way in which we can use the social media, and I'm certainly not an expert on this, to try and counter some of those messages that are going around, because I think all the other more traditional methods that we'd like naturally use, all the things I used to use when I was running a trust, that we've moved on and we need to do something very different. And I do think we need to fight the social media with social media.
Thanks, Anne. Rowan?
Quick one this. Thank you for the passion and the importance. Please match this with ambition. I think to bring the overall level of vaccination to still less than half of our staff at the end of this season strikes me as not us being our best selves around expectation. So I would even offer, before we take this to our adult social care, could we please seriously consider upping the level of ambition for 25-26? Thank you.
And Rowan stole my point
Sorry.
I was flabbergasted when I saw that ambition about 5%, given where we used to be at. So, Julie, are there any final reflections from you or asks of this board?
Just to thank you for, well, it's exactly just what Rowan said. Let's meet this ambition.
Great, thank you. Okay, so we move on. Claire.
Yes, excuse me, thank you. Our colleague Chris Lees is coming up to the table, and Louise Barry are going to present a report on how we are working to improve GP access in line with both national planning guidance, but also, again, because it's the right thing to do. And then Louise is going to talk a wee bit about a survey that we commissioned sort of as a temperature check in between the two national surveys. The national patient survey has just been published for this last time, and Chris will touch on that as well. So this report normally sits through System Primary Care Committee, and we did receive an initial report earlier this month, but because it's one of our key priorities, access, and I know we've brought papers to board before, it's just the next version of that. Thank you.
Thank you, Claire. And welcome again, Chris.
Hello, thank you. So Chris Lees, Associate Director of Primary Care. As Claire says, over the last 2 years, I've sat in front of you a few times to talk about the patient improvement, the access improvement plan for the ICB. And as part of that work that was originally started in 2023 and covered 2 years, 23-24 and into 24-25, prior to the last election, there was an ask that we did additional patient experience feedback work to understand the impact of the things that were being put in place. Hence, Louise is here just to touch on that shortly. At the same time, and coincidentally, a few weeks ago, we had the National GP Patient Survey released, so we're able to do a quick presentation on the high-level summary of those findings. So you've got 2 sets of patient experience together. And then the paper also outlines the approach to access improvement for this year in response to the National Planning Guidance and the 10-year plan, and I've just outlined that in the paper. The detail of that we go through at the System Primary Care Committee, accumulating in a plan that was signed off at the last System Primary Care Committee, which has been submitted to NHS England for them to approve and be assured that we have plans in place to meet those asks, and we're just currently waiting for national feedback on those plans. So I don't know if you want to go now to Louise.
I need to sort my glasses out. Right, thanks, Chris. Yes, so as outlined, the 9 Health Watch across Cheshire and Merseyside were asked to have a look at the impact of PCARP is the easiest way to say it. So the primary care access recovery plans that were submitted from each place to do the overarching Cheshire and Merseyside place. So the 9 of us got together and devised a questionnaire. We put that past people within the ICB and then embarked on speaking with our public. So we did that between October 24 and March 25, and we received views from nearly 7,000 people across Cheshire and Merseyside, circulated using mixed methodology, so in true independent Health Watch style. Some of it was literally on the streets chatting to people. Some of it was surveys that were emailed out. Some of it was surveys that we went into smaller community groups and gathered the independent voice through those methods. So there were different ways, mixed methodology for the engagement. What we found is that we got mixed, with that I guess comes, because it's 9 different places, 9 Health Watch, was a variation in response rates. However, the themes were consistent. So yes, different response rates in different places, but the theme's consistent. There is an overarching report, which is when you have the slides, it is linked, but I can ask for it to be circulated independently as well. And within that, there is an opportunity. So there's an overarching report, but then there are 9 place reports that look at what happened in each place. There is the opportunity to drill down into individual PCNs, neighbourhood levels, GP practices, but that would need to be done on a place-to-place basis. It's not been done for now. So variation was the theme. So what we found is that there was lots of different ways of people getting into and accessing their GP services. But I think whilst this is a snapshot, I do urge people to read the full report because, as we say in Health Watch, for us, every comment counts. Those comments are people's lives, people's stories that they're taking time to share in order to help shape services. So what we found, well, in terms of accessing, when asked why people hadn't accessed, 70% of people said that they'd not accessed their GP because they found it too hard to get an appointment. Now, we are very clear that that's going to be a mix of perception and actual accessing of appointments, but we also believe that perception is just as important. We need people to understand that actually this is doable, you can do it. It may not be the way you used to do it, but it can be done. 66% of people did this via the phone, 21% of people still wanted to go in person, and only 12% of people used anything relating to online, be that an online service or an app. 67% of those that tried to get through on phone reported queuing. So we know about the 8 o'clock rush, we know it's in the 10-year plan, not least because Health Watch had reported on it. Receptionists didn't get good press as part of this report, and I just want to put that into some sort of context. They are the first point of call. They are likely to be the ones that people most quote as having difficulties with. Because we also got positives in other areas to say, actually, receptionists were great, but it's this gatekeeping. And the gatekeeping, as far as I'm concerned, or as far as the findings say, is that people do not understand what the different roles are within our GP practices. They don't understand it because it's very rarely explained and because it differs from practice to practice. So even on a neighbourhood level, you can have all sorts of practices offering different roles. So your neighbour could have a completely different service from their GP these days than happens elsewhere. That education is vital, and it's been a long time coming, and I've yet to see anything that's demystifying it. And I think it's really important when we work at our neighbourhood levels that we make sure our residents understand what it is that's available to them. 85% of people felt that when they got their appointment, it was with the right person. They might not have understood why it was that person. They might not have understood or even wanted to go and see or speak with that person. But actually, once it happened, they got it, they understood it, and they benefited from it. So on to that becomes a satisfaction. So we can see in the report that there's lots of dissatisfaction. We can see that there's lots of challenges. However, 92% said that they were happy with the way the appointment was delivered. So we can see some perceptions versus realities versus confusion throughout this picture. In terms of accessing care through other methods, it was confusing. I know personally at Health Watch Cheshire, we've recently done, as Adam knows, a report on pharmacy, and across the Health Watches, we've done plenty of work on dentistry. And we know that using alternative services, not really understanding what's out there for you, can compound the issue and mean that people are delaying their treatment as well as struggling to get treatment. So there's both of those that are playing out as part of the report. So next steps. We're going to continue doing our listening. It's what we do at Health Watch Cheshire. Health Watch, I was going to list them all, but we'd be here forever. At the 9 Health Watches, it's what we do. It's how we ensure that we're keeping people abreast of the information. It's a two-way thing. We don't just ask what the issues are. We make sure that we signpost and tell people. But actually, we need the information as well. We, being anybody around this table, need to know what goes on within those different practices. I go back to neighbourhoods. These individual reports will go to place leads, they'll go to primary care networks, local authorities, VCFE in place to help conversations. We'll continue to monitor the impact, and we'll see what's coming through our system, and we'll see what's being told to us when we're out engaging with, I think as Ellen said, real live people. So we'll make sure that we're gathering that. We have committed, and Chris and I've had that conversation, around providing that verbal update as to the state of play into the Primary Care Committee, which I sit on behalf of the other local Health Watch. And we're going to follow closely this movement to neighbourhood working and the impact of that and the
the monitoring of that to see that that impact is the correct one, that people are understanding what's happening for them at that level. I think it's vitally important. So I urge people to read the reports. There's a lot of comments. The overarching one has snapshots. The place ones then have local snapshots. And if you so desire, you can go and read every single comment, as we all have for analysing this. It's out there. It's readily available. It'll be through to you. And just, again, a plea. People sometimes say, well, how many people did you speak to? I think 7,000 is not bad for the way this was commissioned. Different amounts in different places. But for me, how many is enough and how many isn't enough? Because if we're hearing these consistent messages, then that's the messages we need to be listening to. Thanks, Chris.
Okay, I'll do the GP patient survey now. Could somebody click me on? Louise, would you mind? Thank you so much. Okay, thank you. The slide before, that's one. Thank you. So the GP patient survey is administered nationally to patients across the country, and the results are available at national, ICB and PCN level. And this year we're lucky because this is the second year of the new survey. Thank you. So we're able to compare last year to this year directly with the questions that were asked last year, if that makes sense. So what I've pulled out for you there is the first two columns are the ICB average of the questions for last year and this year. Then the third column is the national average. And then I know Eric is very keen on this. Our two neighbouring ICBs, Lancashire, South Cumbria and Greater Manchester. So you can see the headline results there and any improvement or changes. I've tried to group them into the themes as a patient goes through their journey. So from making the appointment, how did they feel during the appointment, were their needs met, and then reflecting on their overall experience. So you can see how that's been tracked and monitored over time. So I hope that was useful. I've then just pulled out, again, there's almost 50 questions in the GP patient survey, so to do them all, we'd be here all day. Some areas of concern that were mentioned when we wrote the Access Improvement Plan around access by telephone. So again, this is going to echo some of the things you've just heard Louise say. So access by telephone, although it's fallen, still remains the most popular way of accessing services. But feedback is from patients that is getting easier. You can see the two results in the brackets there are last year and this year. But we're also seeing evidence of functionality in telephones in the feedback that patients are giving. So patients acknowledging that they had a callback, that they were in a queue. When they were on the phone, they were receiving updates. So they weren't left wondering what's going to happen to me whilst on the phone. But we're also seeing a rise in other forms of access. Although it's still smaller than telephone, you can see online and NHS app feedback is growing. In terms of convenience, again, the convenience of the appointment has risen slightly, and also the other concern that was raised by patients was around, can we still get face-to-face appointments? And you'll see that face-to-face appointments were the most common in the survey for the outcomes that patients reported. Although appointments with a GP has fallen slightly, that's because there's a range of staff within the practice that patients will be seeing now. So I've just attempted to pull this together into 4 themes, which I think would hopefully match some of Louise's findings. So the first box is around addressing variation. So in that first box on the top left, you'll see the bracket figures are the variation in scores between practices. So there is variation across the ICB, and as part of the June plan work mentioned in the paper, that is what we have a framework for now. So we're looking at how we address that and how we take that forward. In the second box at the top, there's something about our success, where we're doing really well, where things are working really well, showing that more systematically across place and between ICBs. And that's a piece of work that's already underway and is also outlined in the June plan details. The bottom left box, I've given it quite a grand heading there, but I think I'm going to phrase it as we need to make sure we're taking everybody with us. So one of the things you've heard Louise say is everybody able to use the NHS app? Does everybody understand what the range of roles is in a GP practice? Clearly, we're seeing that isn't the case. So there's something about further actions to ensure that we're taking all our population with us in this new modern general practice world. And then the last box, the bottom right, I can see there's GPs present. Will probably appreciate me mentioning this, but demand. Demand is increasing. Demand for services is going up. Are the future models, you've heard a presentation on neighbourhood health, how is that all going to come together to help us manage demand better in the future? So that's a nod about not forgetting that we have future models coming up that could address and support how we manage demand into general practice. So they ask for the board is to note on the updates on the patient experience and the plans for 25-26. And Louise and I are happy to take any questions. Thank you.
Thank you, Chris and Louise. Any questions or comments from board members? I've got Naomi, Anne and Erica.
So thank you to Louise and to everyone at Health Watch. I've seen the longer version of that presentation, and some of the comments are really stark, and I think it needs to be a bit of a wake-up call for general practice. I think one of the things that needs to be made totally clear is that although we're talking about GP appointments, this is not appointments with a GP. This could be appointments with a physio, a pharmacist, a podiatrist. It could be appointments with a social prescriber. There is such a vast range of people who now work within general practice, and I absolutely agree that the comms around that need to be clearer for patients. There are some GPs who still don't fully understand what a social prescriber does, so how we expect patients to understand that? You know, we need to give accessible information to our patients about who they're seeing and why. So along with that, I think it's so important that this narrative around you can't get appointments with your GP. It's there in social media, it's there in the media in general. You know, I've had patients come and see me and say, oh, I've had this problem for 3 months, but, you know, I've not been able to get an appointment with my GP. And I can now, using the data that's now available to us through the digital access, I can say, but we've had appointments every day for the last 6 weeks. You know, why have you not come sooner? Oh, well, you just can't get an appointment with the GP. So it's this kind of, this story that people are it's that narrative of you can't get an appointment with the GP. We need to change that. We are providing more appointments than we were pre-COVID. There are more appointments available. It just might not be with a GP. It might be with someone else. So I think this is really important to be able to look at the facts and the figures and to look at the narrative going forward. We need to be able to explain that to patients.
Thanks, Naomi. Anne?
I'm the great champion of the digitally excluded, and I really worry about, because often that will be some of the more deprived sections of society, and certainly the more elderly sections of society who you might say, you know, certainly deserve as much access as anybody else does. So there is this kind of always this mantra about let's just do everything digital, and there's a whole load of people who need these services that can't do digital or don't do digital or whatever. But so even so, allowing for the fact that you keep the phone calls going as well as keeping the digital access going. How do you understand how that works? How do you assure there's equity of access between those who can access things digitally and those who have to do that horrible thing whereby, I know what you're saying, Naomi, but you do have to still phone 400 times.
So you don't anymore?
Well, maybe not
just
in your
clarify,
practice,
no,
but in mine.
So the
Yeah.
digital access and the digital offer is that you ring up and you are told where you are in the queue, and you press number 1 if you want to call back. So when you get to number 1 in the queue, you are automatically phoned back then. So patients should not, again, it's about getting that information out to the general public that you don't have to ring. And there are lots of practices now who've actually stopped the 8 o'clock rush, so they don't have that. You know, I can give examples of different practices in Liverpool who've changed their appointment system in order to prevent the 8 o'clock rush. So, but it is still this narrative of the 8 o'clock rush and you can't get an appointment with the GP. There are lots and lots of projects and pilots at the minute to reduce that. But you definitely, within Cheshire and Merseyside, we all now are signed up to the digital offer, and you should not be ringing your GP practice 400 times.
But even if you're not digital, if the digital offer doesn't work if you're not digital, does it?
No, so the digital offer isn't about a patient going onto their iPad or onto, you know, even using their phone or using the app. The digital offer it wasn't actually patient focused. It was actually general practice focused, so that we could. The digital offer is that the phone system is now digital. So the phone system can tell us how many calls we've had that day, how many patients have tried to access, how many patients have actually given up. They've not waited, they've just dropped the call. The vast majority of our appointments are still booked via phone. you know, particularly I work in a very deprived area, so it's over 99% of our patients book via telephone. But we can see that data now. I couldn't have told you that this time last year because we didn't have that data. But what the difference that it's made, and we've been able to see that through the national survey, is that patients, they now have a much better, we've improved our score on access, because patients now hear, you are number 13 in the queue. Please press 1 if you would like us to ring you back when you reach number 1. And patients are doing that. It's taken a while.
So the
Sorry.
Messages come out really loud and clear. Yep. I mean, we have to get the message out further. Chris, there was 2 parts to Anne's question, and that was the other part was how are we sure we're not having unequal access because of a push to digital? Do you know?
Yeah, I think Naomi touched on it. We have a range of information now that we can look at to see, for example, we have a separate dashboard on the NHS app usage, so I can go in there and see practices where nobody is using the NHS app, and that will flag under our variation work what's going on with that population, why is it so low. So a part of our role as a commissioner is to look at that data and understand what's going on in that practice and that population. And the same with some of the feedback you're hearing from Louise and in the GP survey. We know there are people who are not keeping up with the technology. So as part of the June plan, we've put in some actions to support that. But clearly that's a piece of work, isn't it? It's not going to be done overnight.
Thank you, Chris. Erica?
A reassurance as Chair of Primary Care, and a thank you to Chris, because you can see the amount of data that we're pulling together now, but we are getting to a point when it is the right data. So we've got metrics, we've got the narrative that's coming from Health Watch. That information is quite rightly going through to place and PCN level, and what Primary Care Committee then is an oversight and a support. But what we're keen is not to spend all our time bringing, if we're talking about variants, bringing people up to acceptable, that we're still striving for that exemplar work as well. So that it's kind of twofold. We want to make sure that we've got minimum standards, everyone's got that communication, but we're still driving out with those really good PCM practices. Thank you.
Fantastic, thank you. I've got Ruth and then Claire. I'm going to close it on Claire.
Very briefly, and I was going to come in on the variation and bringing the service up to a consistent level, and really welcome the idea that we keep striving on as well. But for the board, I mean, you probably discussed this in committee, but for the board's benefit, what's the scale, what proportion of practices are deemed to need the support? What's the nature of the support, and what's your confidence in terms of performance improvements? What sort of proportion are we talking about?
Chris, can you give us an overview quickly?
Okay, so how we approach variation, what measurements we use, and what support we can put in place are all outlined in the June plan. So there is a level of detail. Some of that relies on data, and some of that relies on patient experience feedback. We have got metrics and, shall we say, benchmarking that we need to use, and we outlined in the June plan that show where we need practices to really all strive to get to. So there is a long level of detail. I'm sure Erica will see the plan is actually about 35 pages long, so we can provide that detailed plan to the board to have a look at. But it's an ongoing piece of work. Does that answer the question, or is there a bit more?
I think it's just a headline.
Quickly, I think if I've got the figure right in my head, there was about 23 that were initially, just to give you a size.
Exactly.
This is new for us, so that Place will then propose, you know, with the PCNs, what actually is going to happen, and that will come to us. But that is
yeah, we had an initial list of 23 practices that were flagged as, let's call them level 1, and then about another 50 that were level 2, just underneath. But with every time that data it changes, so the data in the new from the GP patient survey will change this year. Some new practices will come onto that list, and others will go off. So it's an ongoing piece of work. And the second big, just to assure you further, we've already had inquiries nationally about what we're doing about some of these practices from the National Secretary of State's office. So that's an ongoing piece of work as well. So there is real scrutiny on how we're addressing and working with outliers.
Thanks, Chris.
I think what I was going to say was about variation. It is about how we reduce variation across Cheshire and Merseyside. There is considerable variation across the places, across and within the places. So this plan is helping to, well, I suppose, shine a spotlight on that and then reduce it. But you can even see in appendices 1 and 2 of Chris's report some of the metrics we're using. And I think, as Erica said, you know, using that really rich data now gives us information, and then we can base our plans on that and the commissioning. So it's just a huge thanks to Chris and Louise and the team. Thank you.
Good. Thanks, Claire. Thank you, Chris, and thanks, Louise, for the presentation. And we've met the two requirements, which is to discuss, and we have discussed it very certainly. Let's move to the final main item of, the final agenda item. I'm going to get my words right now. It's not the final agenda item, it's the final paper.
It's
which
the
is going to be
final
led by
agenda
Claire.
item, substantive item of the public meeting.
Let's go with that one, yeah.
Right,
I'll
okay,
go with
whatever.
that.
So, Neil's going to talk through the detail here, but if you remember, we signed off the high-level annual delivery plan 25-26 in March, but we made a commitment to come back to board with more detail and to talk through our strategic tracker. Neil's going to do that because I think it's important to give board assurance that we are monitoring this, and we're doing it jointly with Anthony's team, and obviously a lot of the metrics are within the integrated performance report, but there are others as well. So Neil will just talk through that, if that's okay. And I think it'd just be helpful, because obviously this is the annual delivery plan we need to think about as we move into next year as well. So it'd be helpful to get some feedback. Thank you.
Good. Welcome, Neil.
Hello, good to be here. So for those who don't know me, I'm Neil Evans. I'm the Associate Director for Strategy and Collaboration at the ICB. As Claire said, normally we would have updated our joint forward plan, but in light of the national picture with the 10-year plan, the new operating model coming through, alongside other changes such as local government reorganisation, there was a national move not to update joint forward plans this year in full, but to locally develop some interim annual plan, which we've used our annual delivery plan to fulfil. The document that we've included is what we call our tracker, which takes each of the programmes that are included in that annual delivery plan and provides a set of metrics and measures that we use to monitor progress in delivery of the plan. It's not dissimilar to the one you will have seen last year in format, and we look to separate that into two appendices. You'll have seen they have the same information, but one is a board level report and one is our full tracker, which we would look to oversee through our board subcommittees and wider governance, recognising at the moment it's built on the current governance, and as we make any changes to our ICB governance in the coming weeks or months, we would look to refresh that to make sure each part of the plan is being tracked and monitored. You will hopefully have seen, I recognise there's a lot of detail in that full tracker, so you may not have read it line by line. But I hope that gives the assurance that the board was looking for, that we do have in place detailed metrics and measures. The board reporting would come through the IPR that Anthony's team produce each month, and we've worked very closely with Anthony's team to make sure that everything works is synchronised. But as I say, the full detail is behind there for your information, and we'll continue to work with our programme leads as some of those plan areas develop over the year. So I know you've talked about neighbourhoods in detail today, so we recognise that's an emerging and growing programme, and similarly our financial sustainability programme continues to develop and build, and we will update the plan in the background to reflect those changes through the year. So I won't go into more detail. Hopefully the paper was relatively clear, but happy to pick up any questions.
Yeah. Thanks, Neil. The paper is clear, but it's quite a hard task of board members to go through this and think, well, is there a gap? Do we want to evolve or do we want to change? So I'm going to suggest that, given the specific roles of the non-execs, I think it's well worth us as non-execs having an hour on this, supported by you, Neil, and we'll run through it and gauge it against what we believe the key priorities and the strategic plans are that we think we wanted to see at board. Is that a reasonable suggestion, Tony?
I think for Claire and I to be involved in.
Oh yeah, of course.
That.
Welcome.
Thank you.
You're welcome. Absolutely. I'm trying to include you. Yeah, absolutely.
Yeah, I was just going to suggest that I think it's a great idea. What if we could get some in-front feedback, it might be helpful to get some of our programme leads there as well, because of course the content of these programmes is very much developed by the leads for those programmes with myself and Stephen, who works for me. So if you wanted to delve into neighbourhoods, people like Claire and Alison would of course be key, mental health, Simon Banks, and so I think it's important we get the right people there to have a rich conversation.
Yeah. Absolutely, but let's do it in phases. I think there's a first conversation about what do we know now and how do we want to monitor that through the board level reporting. And I think there's another question for that session, which is, as we develop strategies, how do we determine the indicators that we want to include in the IPR process? So those 2 points are pretty important. I'm just going to take any quick comment on this first bit. People reasonably comfortable with this? Yeah? Is there anything else you want to cover, Claire, on this?
No, I think, I mean, as Neil said, it's a moment in time, and I guess the challenge is, we're now in July. I'm sure we'll be asked to do our plans for next year. I think by Christmas, talked about commissioning intentions. So I think there's something about reviewing it now, but how we use this as a step forward into next financial year.
Okay.
Thanks.
Okay. So we'll action that meeting with Claire, Cathy.
Yeah.
Okay.
We'll have senior
Thank you.
representation.
Right. Let's move on. Minutes of the previous meeting. Are there any matters, accuracies or comments on those meetings that you want incorporating before I move to approval? People happy to approve? Thank you. There's a board action log there. I am not going to go through it just today. You can see it's in front of you. We need to keep it up to date, and it's improving, but it's still not where we need it to be. So let's keep it up to date, please. And closing remarks. It's been a really, really productive and at times enjoyable meeting on those topics where we're looking forward, but we know also there's some immense challenges, aren't there? But thank you very much for your really active participation. So I'm going to formally close the public meeting. Thank you to members of the audience for sticking with us, and hopefully it was mostly intelligible to you. But as normal, we'll see you at the next public meeting, and there's lots of information on our websites. Thank you.